We humbly acknowledge that Johns Hopkins University is located on the traditional and contemporary homelands of Indigenous peoples. And as we gather together virtually from across the country, we acknowledge the Indigenous peoples who stewarded these lands and respect that we are all on native land. As for our Johns Hopkins campus here in Baltimore, we reside on the unceded lands of the Piscataway and Susquehannock peoples. We recognize the enduring presence of more than 7,000 Indigenous peoples in Baltimore City, including Piscataway, Lumbee, and Eastern Band of Cherokee community members. We acknowledge the history of genocide and ongoing systemic inequities while respecting treaties made on this territory as a step towards reconciliation and strengthening relationships with Indigenous peoples. We give thanks to the past, present, and future stewards of this land and respect all tribal nations' sovereignty and right to self-determination. We aim to hold ourselves and the university community accountable to tribal nations. Thank you.
Good morning, and welcome to the Bloomberg American Health Summit. And now, a message from Michael R. Bloomberg, WHO Global Ambassador for Non-Communicable Diseases and Injuries, founder of Bloomberg LP and Bloomberg Philanthropies, and the 108th Mayor of New York City.
Hello, everyone, and welcome to the 2025 Bloomberg American Health Summit. Let me start with a big thank you to Josh Sharfstein, Michelle Spencer, President Daniels, and our longtime partner, now in a new role at the helm of the Johns Hopkins Bloomberg School of Public Health, Dean Pollack Porter. Congratulations, Keshia. Our work together really couldn't be more important right now. Across the country, public health is under strain and under attack. Defending it while driving progress on America's most urgent health challenges starts at the community level, and that kind of local impact continues to be a hallmark of this initiative. Since we started in 2016, more than 400 fellows from over 40 states and territories and a wide range of career fields and disciplines have led progress from the ground up. Their work is reaching millions of people, and this summit is all about strengthening our efforts in the years ahead. We think you'll get a lot out of it. So thanks for being here, and all the best.
Please welcome Dr. Joshua M. Sharfstein, Director of the Bloomberg American Health Initiative, and Michelle Spencer, Deputy Director of the Bloomberg American Health Initiative.
Well, good morning. Good morning. Welcome to the 2025 Bloomberg American Health Summit, and thanks to Mike Bloomberg for his support and inspiring words. Josh, it's your turn. Please read the monitor.
Michelle, I'm just enjoying the moment. You know, this is one of my favorite days of the year. Just look at everybody. Look at all the fellows, our partners. It's just great.
Have you enjoyed the moment long enough?
You know, honestly, it hasn't been the easiest of times. I just want to soak this all in so I can let it out bit by bit over the next few days, weeks, and months.
I get it. I understand. There's a lot of challenges facing public health these days. We'll be talking about some of them this morning and about how public health is really hanging tough.
Michelle, you and I have worked together for nearly 20 years now. We've seen funding cuts, but not funding cuts like these. We've seen attacks on public health, but not attacks like these. We've seen moments of polarization and anger, but not divides like these.
Which makes the work that we do of improving health even more important. Just look around, Josh. Even in the face of these challenges, people in this room, working with organizations devoted to the health of their communities, are helping to achieve major declines in overdose, in violence, in homicide, in teen violence as well. They're fighting to save the environment and to improve access to healthy foods. We can't stop now.
Today, we'll be talking about upholding the values of public health in changing times, about standing up for evidence, for integrity, and for the idea that everyone should have a fair and just opportunity to be as healthy as possible, the definition of health equity. And about courage from the front lines of public health all the way to the top of CDC.
Our goal with the Bloomberg American Health Initiative is to keep the beat of health going strong and with a little excitement and joy.
Okay, Michelle, so how do we really get this 2025 summit started? How about a movie with an orchestra?
We've been there, done that, 2018.
Oh, okay. How about a magician who only works over Zoom?
We did that in 2020. I can't believe we did that.
I can't believe we did that either, actually.
Oh my gosh.
Okay. Good Morning Baltimore?
Nope, 2023.
All right, so what's your idea?
I was thinking maybe a duet between the two of us.
A duet?
Yeah, like, ain't no stopping us now.
We're on the move. Okay, I'm thinking let's keep the beat going, even if it's going to be a little bit loud. Please join me in welcoming the Morgan State University Drumline. That was amazing.
Absolutely amazing. What's coming next is also amazing. Our new dean, Dr. Keshia Pollack-Porter.
Thanks to Johns Hopkins President Ron Daniels, from the beginning of the Bloomberg American Health Initiative, we've had some terrifically supportive deans. Mike Clegg got the initiative started.
Ellen McKenzie put her heart into this effort.
And now one of our founding faculty members is the dean. An expert in injury prevention, health equity, and public policy, Dr. Pollack-Porter is inspiring.
And thoughtful.
And ready to lead.
Please join us in welcoming our dean, Dr. Keshia Pollack-Porter.
How many people get to say they're welcome to the stage with the Drumline? Come on. And actually what makes that so special is I was a drum major in high school. Deer Park High School in Long Island. Anybody from Long Island in the room? All right. Oh goodness, well, I'm thrilled to be here. On behalf of the Bloomberg School, I want to thank our neighbor, Morgan State, for their long-standing partnership and for enriching our shared city of Baltimore through their scholarship, research, and service. I also want to thank Mike Bloomberg for his encouraging words and for his fierce and unwavering support of public health. Mike's vision for a healthier America and his conviction that together we can build it are the reasons why we are here today. Join me in welcoming and thanking Mike Bloomberg, please, again. I'm proud to say that I've been part of the Bloomberg American Health Initiative from the very beginning. And I'm honored to hold the position of Bloomberg Centennial Professor in recognition of my leadership of the school's Institute for Health and Social Policy. But this is my first summit as the dean of the school. And as I stand here before you, I acknowledge that my appointment is history-making. The Bloomberg School was founded in 1916, and I am the first Black faculty and only the second woman to hold this role. And I am grateful to everyone whose journey made it possible for me to stand here today. I have always taken pride in being first at something because it paves the way for the second and for the third and for so many more. And I know that out here in the audience today, there are so many of you who've broken barriers and blazed new trails. You remind us all of what is possible and that change is always in our reach. And what we see now is not the way it needs to be. I would not have applied to be dean of the Bloomberg School if I did not believe that the future could be different than it is today. And it is no secret that this is a difficult time for all the work that you do in public health. We are witnessing cuts to the global and national workforce and programs, rapid changes in policy. This is a defining moment, but our community is strong. You are strong. And we are ready for the challenge, and I know that together we will achieve what we are setting out to achieve, and there is nowhere else I'd rather be than here with all of you. I vividly remember the hope and the spark of the initiative's early days as Josh and Michelle laid the groundwork for a bold new effort to improve health and save lives across the nation. I have watched year after year as we welcome new fellows and new partners to join the work. That first year, there were 8 fellows. Today, there are 448 and growing. Every one of you is on the front lines of change. You're advancing suicide prevention, turning vacant lots into playgrounds, bringing addiction treatment to primary care settings, and so much more. And if I could just take a moment to celebrate a recent piece of news. Last week, we announced that Dr. Mudia Uzi, who's in the room, I hope, who graduated from the Bloomberg School in 2022, officially joined the initiative. Moody is a Bloomberg Assistant Professor of American Health in the Department of Health Policy and Management. And I'm going to celebrate myself because I hired Moody to the faculty when I was chair of the department. Moody is doing great work in violence and overdose prevention, and his work helps us to understand the underlying causes and work towards lasting solutions. I'm so proud of what he has achieved, and I'm so proud of what each and every one of you who is part of the initiative has also achieved. You all embody resilience, innovation, community impact, and most importantly, hope. As hard as this moment may feel, I assure you that this is not the time for despair. This is not the time to feel hopeless. The writer and activist Alice Walker once said, "The most common way people give up their power is by thinking they don't have any." I want to recognize how much power is in this room today. And I'm not talking about just the people in elected office. I'm talking about each and every one of you. There's power in your education. There's power in the evidence you gather and in the science you pursue. There is power in the deep connections you have to your community and to each other. There is power in the Bloomberg American Health Initiative. And I take strength and hope from being here with all of you in community, united in our shared mission to build a healthier and more just world for every single person. And I truly believe that together we can achieve what may now seem impossible. Thank you for being here. Thank you all. Now it is my great pleasure to introduce Ron Daniels, President of Johns Hopkins University, a tremendous leader in these challenging times.
Well, good morning. Good morning. Thank you, Keshia. I am delighted, truly delighted to join you for your inaugural Bloomberg American Health Summit in your capacity. Wait, Keshia, you can't go. Just wait a sec. In your capacity as the 12th Dean of the Bloomberg School of Public Health. You know, people allude to this being a challenging time for public health. That is indeed true. It's a challenging time for universities and indeed for university presidents. And there's lots of decisions that you're forced to make that you never dreamed in this, that you would have a moment when you would have to make decisions of this character in response to the kinds of challenges we're facing. But for me, this past year, the easiest, most straightforward decision, the most obvious decision I had to make was to appoint Keshia as the next dean of the Bloomberg School. That was a delightfully easy decision. So Keshia, thank you for your leadership of the school at this critical moment and your steadfast commitment to public health through efforts like the Bloomberg American Health Initiative. You can go now. And to Josh and Michelle, the comedy stylings, I'm trying to get a sense year over year, whether it's getting better, staying the same, getting worse. Josh, Michelle's good. You stick to the podcast. As Keshia shared, it is the common aim of sustaining more than a century of public health impact that brings us together today from across the country. Indeed, we see that impact manifest through small-scale interventions, which, when collaboratively designed and executed, can transform the health and well-being of individuals, their families, and their communities. We see it in the efforts to ease food insecurity for families in New York City with community summer meal programs, to save lives from suicide in Puerto Rico by changing how local news reports on these tragedies, and to integrate addiction treatment into primary care programs in Texas. And we see that same spirit evident right here in Baltimore in the work of the Innovation Fund for Community Safety, which is launching its second cohort of academic community partnerships this year to bring a grassroots informed approach to bear on safety and violence prevention efforts in our beloved city. No matter where you're joining us from today, each of you is here because you share the firm belief that the solutions to our greatest health challenges will only succeed if they have the support of the communities they are intended to serve. But as you well know, to succeed, this work requires extraordinary trust between our public health institutions and practitioners on the one hand and our communities on the other. And yet, as we know, this trust has eroded over the course of the pandemic and continues to struggle today. As trust has waned, so too have the resources that long powered this work. Dramatic funding cuts to public health efforts nationwide will contribute to the rising cost of medical care, increased hospitalizations for once preventable diseases, and an ever-widening gap in life expectancy evident within our nation and among peer nations. As we seek to prevent these outcomes, the questions before us are, how do we revive trust in and restore public support for public health? How can we ensure the field's guiding promise to deliver results for our communities continues to be fulfilled? I believe that the work that you are doing here through the Bloomberg American Health Initiative, as well as the work that you're pursuing in your communities, is a crucial part of that answer. We see the partnerships you forge, the insights you glean from deep immersion in and dedicated collaboration with the communities you serve, and the capacity you have shown to bring rigorous analysis of evidence, including the evidence derived from those experiences and insights, to shaping effective public policy. So as we navigate this challenging moment together, I thank you for bringing your ideas and your perspectives here, and in turn taking the best ideas of these days together back to your own work in cities and towns across the nation. We're so very proud of the work that you're doing and the impact that you're having. So, thank you for being here. And now it is my great pleasure to introduce Michelle Taylor, Commissioner for the Baltimore City Health Department, and ask Michelle Spencer to come back up, Deputy Director, of course, of the Bloomberg American Health Initiative, who will share more about how we are partnering to strengthen the health and well-being of our home city. Again, thank you all for being here today, and I hope you have a terrific, terrific summit.
Well, Dr. Taylor, welcome to Charm City.
Thank you. Thank you.
So let's get this going.
Absolutely.
In what ways are the impacts of redlining and other longstanding systemic inequities that shape health in Baltimore similar to those that you've dealt with in Shelby County?
Absolutely. So first, it is such an honor to serve this great city. Welcome to all of you all to Charm City, my new city. The accent that you hear is Memphis, but I am so honored to be the next Commissioner of Health for Baltimore City. And the reason why Michelle is asking me this question is because she heard me tell a story about when I was a pediatric resident and I visited the Shelby County Health Department for the first time. And vital records, I found, was color categorized by race. And I knew that because I was in a group of residents who we were all training, we were all spending our week at the health department. It was my first time in the health department, even though I was a native of Memphis, but the other residents weren't from there. And the first room we went into was vital records, and the lady that was over it opened the drawer and she said, "What do you see?" Other residents were just puzzled, and I knew exactly what I saw because my family had grown up there. My parents were both born and raised there. Orange cards for African Americans, white cards for white residents, yellow cards for babies that were stillborn that year. And so I tell that story often to remind people that the policies that were created many, many years ago, you're sitting in the birthplace of redlining, affect health, affect population health even today. But the good news is that we know that with good policy, we can also affect health. And that's why all of you all are here, to lend a hand, to lend your expertise, to lend what you know, to protect and improve the health of the populations that you serve.
So as you're taking on this challenge of Baltimore and the issues that you're seeing and the issues that are facing, we know that we have seen declines in overdose deaths. We've seen declines in violence. Here in Baltimore City, how do you begin to prioritize given our historic policies, the structures, but yet the innovative approaches and the opportunities that are possible?
Absolutely. So what you must always remember is that there are questions that you have to ask before you can start to prioritize, especially in a local health department. What are you statutorily required to do? That has to get done. Everybody knows that. Whatever organization you work for, there are things that you are required to do in your position and in your sphere of influence. The second is, what do you do better than anyone else? You may not be required to do it, but there's no organization that can do it better than you. And finally, what are the things that maybe you don't do as well? You're doing them, but if you partnered better with an organization that does do it better, how would that improve? I was sitting in a meeting yesterday with a group of judges and lawyers and other folks in social services dedicated to overdose response and behavioral health response. And we talked about, at the end of the meeting, what does it mean to be somebody from start to finish who has a mental health crisis, enters the system, is mandated to treatment, and then they have treatment because of insurance coverage, but maybe they're not getting all the resources that they need during that treatment, just for the extra things. What does it mean to only get $30 a day for basic needs? What does it mean to not have any extra resources, and how does that feel? The reason why I love public health professionals and people who have dedicated their life to this work is because even if you haven't had that lived experience, you have dedicated yourself to figuring that out for people who are having that lived experience. And that is how we get to better policy and better health outcomes for everyone.
So you talk about the whole person, from birth through the entire life cycle. What are the ways that you think Baltimore needs to, what are the opportunities that's before us here in Baltimore?
Let me tell you something about Baltimore. And the reason why Dr. Jaraza and Dr. Sharfstein and yourself convinced me to come here. I could have stayed in Memphis. I could have ended my career in Memphis. There are people in this room who know that. And everybody was surprised when it was announced that I was coming here. But Baltimore has something different going on right now. Baltimore has momentum. You can feel it in the air. You can feel it in the work that people are doing. But Baltimore also has the means right now to really respond, not only to overdose deaths, but to a myriad of other issues, and has already been responding to help families, to help community, to help in reducing violence, all of those things. And Baltimore is making significant investments significant investments in all of these areas and more to make sure that smart policy is going to actually helping people. And Baltimore has the motivation to do these things, right? So everybody in this room understands that there's only so much you can do. But when there's no political will to do those things, you can have all the money in the world. You can have all the motivation in the world, but if you have no political will among the people who are serving you as elected officials to get things done, to improve policy, to do the things that need to be done, to really, really fill in the gaps for folks who don't have resources, and really to fill in the gaps for an entire community, then you can't get it done. And so I will tell you that Baltimore is special. I'm so excited and so honored to be here, and I know together we can tackle even more than has already been tackled before I got here.
So thank you for that. Let me ask you in the 1 minute and 10 seconds we have remaining. There are policy challenges, there are funding challenges, there are opportunities that we have yet to explore. There is issues across our 5 focus areas that we still need to hammer out. There's disparities based on the 20-life gap based on where you live within Baltimore City. And we know Baltimore City is made up of neighborhoods.
Right.
What are the things that you want us to walk away with, being hopeful about in this moment, given the challenges set before us?
This is what I would tell you. Remember that the colors mattered on those cards. And even though this is the first time we are living through times like this is not the first time that folks who look like us and have had lived experiences like us have dealt with these type of challenges and more. We have every single thing we need to be successful, and no amount of barriers are going to stop us. That's why you all are in this room, because you have decided that no matter what the funding is, no matter what the political climate is, no matter what somebody says in misinformation or disinformation, that we are the experts in the room, and that's not a dirty word. Because when we bring our expertise and our strength to an issue, there's absolutely no one that can stop us. And we must continue to speak up.
Well, we're at time, and I think that's a great way for us to end our conversation. Part of me wants to ask you about the importance of data, but you said it, and I want you to respond. Just give us a second about the importance of data.
You're going to get us in trouble, Ms.
I know. I'm not looking, that's why I'm not looking at any of our producers.
Data is super important. That was the way I made so many changes in Memphis and Shelby County. Because not only were we collecting the data, but we were taking the data and the information back out to the people. Always remember, you must give the public more credit than we normally do. They understand way more than we give them credit for. And when you arm them with information, with the data, they'll be better champions than you ever could be, because they know what the gaps are. They live in those communities. They sleep in beds at night and hear what's going on outside their window. And they know what it takes, but they need to be armed with information to make sure that they are helping you in effective ways to make sure everybody's health improves.
And with that, please join me in thanking Dr. Taylor.
Please welcome Richard Hughes IV. Professorial Lecturer in Law at the George Washington University Law School and partner at Epstein Becker Green, in conversation with Dr. Kelly Henning, Public Health Program Lead at Bloomberg Philanthropies.
Thank you, Richard, for being here. We're going to have a conversation about vaccines, which I think are on many people's minds. Can you just start us off by talking about how did we get here? How did we get to this moment, and why are we here?
Sure.
So this is a very challenging moment for vaccines, and thank you for having me as a part of this conversation. I know that vaccines are not really the main theme of the day, but we're at a really concerning major national inflection point in vaccines. And I think it's really important as we have this conversation that we think about where we've been in the past and how we got here. Vaccine hesitancy is not new, and vaccine misinformation is not new. But we really, I think, saw the exponential, dissemination of vaccine misinformation and disinformation following. There was a paper in 1998 published by a man named Andrew Wakefield that really perpetuated this mythical link between vaccines and autism. And that paper, while it was retracted from The Lancet, it was one of those things that you can't put back in the bottle. And social media, the reporting around that paper, and then the amplification of that through social media, and then the more general amplification through social media of vaccine misinformation and disinformation is really a large part of how we got here. And then we have a health secretary, our nation's chief health officer, who unfortunately has been one of the pillars of the anti-vaccine movement and has been a part of further disseminating that misinformation and disinformation. And I do think that the COVID pandemic, we all experienced this collective fatigue. And I think that the fatigue combined with, in some pockets of the country, frustration over how we communicated about pandemic measures certainly fed into that. Not to mention the populist movement that put Donald Trump back in office.
So, Richard, can you talk about what the states are doing or what the states could be doing around vaccine policy at this juncture?
Sure. So we really are going to see a major federalism shift, and I think that states will play a very critical role in ensuring that we have viable vaccine policies going forward. But it's going to be a mixed bag. States are different. We have red states and blue states. We have states that want to wield their public health powers for good, and some that don't. If you look to Florida, it's very concerning that you have a chief health officer there that, much like the secretary, disseminates misinformation and disinformation. And while states have this great power to improve public health, protect public health, not all states will wield that power that way. And in fact, I think people are surprised to learn that legally, states are not required to do that. So it will take leadership in the states that are willing to step up and protect public health. They will have to ensure that we have accurate information, that we're sharing that information with the public, and that we're implementing policies that protect public health. States are going to have to shore up insurance coverage and ensure that there are clear recommendations. And we're starting to see that in some corners of the country. But states are going to play a really critical role, for better or for worse. I would love to see better leadership at the federal level, but I think it's going to be a long time before we get that back.
And what about this moment? Have you ever seen anything with regard to vaccines happening like we see happening today? Is there any historical reference?
Sure. Well, I haven't in my lifetime, for sure. But if you look back across history, vaccines and precursors to vaccines have not always been popular. These were very unpleasant procedures. The old concept of variolation, where people had these things, smallpox scabs ground up and blown into their nose, that wasn't very pleasant. That wasn't very popular. And so there was always objection. And back in the 1800s, as we started to implement mandatory vaccination policies, there was a lot of resistance. And I think there was acceptance only to the point that we had to do that to stop outbreaks. And then once outbreaks subsided, we saw the rollback of a lot of those policies because the public was really tired of those, of being forced to be vaccinated. And we did forcibly vaccinate some individuals back in the 1800s. But I think we regained confidence in vaccination. And ultimately, throughout the 20th century, we were able to to have good, strong policies. And I think we'll get back to a point where we have public confidence. And unfortunately, I think part of the way that we'll get there will involve a lot of morbidity and mortality that was really avoidable.
So can you give us some thoughts about what we could be doing now to rebuild confidence and to sort of engage the public in this vaccine issue?
Sure. I think we have a long way to go. And I think Robert F. Kennedy Jr. Exiting the role of HHS Secretary will be a great day. Hopefully that day comes soon. I think some recapturing of public confidence in vaccines and public health will be regained, I think, after this administration is out of office. Some of it will take decades, some of it will take a generation. But we need to, and the public health enterprise needs to work really hard to do a better job of communicating evidence and just translating science for the general public. We talk about 90% herd immunity. Well, how about we translate that into we need 9 out of 10 people in this community to have immunity so that we don't have measles outbreaks. And we have to make that translation for the general public. We have to make that translation for legislators. And I mean, that really has to happen at the community level and the legislative districts at the state level. You have to make it, for policymakers, you really have to make it about their constituency. There was a member of Congress last year that said the way the American people understand efficacy and the way the FDA does and the way the FDA communicates about it are two different things. We have to be mindful of that. We have to come down off of the ivory tower, and we have to work to communicate better with the American people. We have an obligation to do that.
Thank you, Richard. Thank you so much for those comments.
Thank you so much.
Next, we're going to hand the program back to Josh in conversation with Yolanda Jacobs, President of the American Federation of Government Employees, Local 2883, the union representing CDC workers, for a very timely discussion on protecting public health. Thank you.
Great.
Hi, Yolanda.
Hi.
Thanks so much for joining me today.
Thank you.
Now, your chapter has more than 2,000 members?
Yes, we have about 2,300.
Tell me about them.
They consist of employees from the IT fields, health communication specialists, biologists, epidemiologists. We even have a couple of EIS officers. So it's a range of positions across the agency.
And how do they generally feel about the CDC? Why do they go to work there?
Many of them go for the public health mission. Some of them plan it from the time they're in college, undergraduate. They're already thinking about pursuing their master's in public health so that they could come over to the agency and, jump in on the mission.
August 8th, 2025.
Horrible time for us. Horrible.
Tell me about that day.
On that day, a shooter attacked the CDC campus. None of the employees were injured, but we did lose DeKalb County police officer David Rose, who attempted to stop the attacker. And since that time, many of the employees have been going through a really stressful period, especially since they've been basically forced to return to the campus where there are still bullet holes in windows, there's still a lot of damage within the buildings, and they're just being asked to swallow the fear and report back to the office. So it's been a really tough time.
It's this incredible tension between feeling like you're going to your job to help people be healthy and feeling under threat at the same time.
Yeah, because a lot of employees, they're not healthy at this time. They're just going through the motions, hoping they still have a job, hoping they can still continue that mission.
Right,
that they signed up for.
It's not as if the rest of the agency has been smooth sailing.
No, it has not been. It's been rough waters.
Yeah, tell me more.
Sometimes it feels like the ship lists to the side and there's no one there to right it. And then other days you think that the seas are just a little bit choppy, but we'll be okay. And then once again, you get that big wave and you list to the other side. So it's been a back and forth, you know, and some of the employees feel like they've just basically been in an abusive relationship and they can't get out.
Wow, that's a vivid image. I mean, you have programs wiped out, funding cuts, then people fired, and then sometimes people come back and then they're fired again. How do you try to support them at AFG?
We provide a lot of resources. When the attacks happened, one of the first things we did is we sought out experts who handle the aftermath of shootings, the people who are left behind that have to process that trauma. And we brought that trauma expert on board, and we held like a town hall, and then we also offered like private consultations with that mental health therapist. So we provided that, we provided information, we helped guide them through the process for people who would need like reasonable accommodations because mentally they just could not, even imagine going back to the campus. And that takes into consideration, we also had some disabled vets who were already diagnosed with PTSD, who were also being told that they needed to come back into what they now considered a war zone.
Yeah. How much of it was frustration that CDC could have done more to be supportive?
I think that there were a lot of opportunities. I don't think that all the opportunities that could have taken were. There were some attempts, but we still feel like it came on the heels of the union beginning to perform in place of the agency, and then the agency being shamed into doing something because it did not feel like there were a lot of people there who cared. I mean, we never heard from some of them. There was never any, we're sorry about what happened to you. We're taking every measure we can to ensure that this doesn't happen again. We're going to speak out against what may have caused this to happen. That never took place.
You know, one of the difficult things for people on the outside is we rarely hear from people who are working inside. That means you and your role in the union is very important. What do you think people inside CDC would want an audience like this to know?
They would want everyone to know that they sacrificed. They sacrificed, I guess you could say, a more stable environment. Some of them sacrificed a larger paycheck. Many of them have sacrificed families, their own mental health, like I said, and all they want to do at the end of the day is to be able to do their job.
Wow. What comes next for you for the CDC?
For me, we will continue to move forward because, some people have said, well, why don't you guys just quiet down a little, put your heads down and see what the next few months bring?
Right, I'm guessing that's not what you're thinking.
We're unable to do that.
It's not a persuasive case.
We don't even know what that looks like. We have no idea. Yeah.
So tell me about that. What do you think should we be aware that you're working on? What is important for people to do to be supportive of the employees of the CDC right now?
What we will do is continue to hold the agency accountable. If that means throwing federal law in their face and, insisting that they follow what federal law says until that law does not exist anymore, that's what we're going to continue doing. If it means media outreach, if it means guiding employees through the process of appealing violations of their federal rights, we're just going to keep doing that. We're not going to go away because the agency says, oh, we no longer recognize you. We are an independent entity and we will continue operating that way.
Right. What can people do to be helpful to CDC right now?
Be a voice for us. When you hear things that don't sit right with you, that are not right, when you know that there are funding cuts to very important and crucial areas of the country, speak out about it. Say something, because a lot of times the agency figures, if we just keep quiet and we let the union run its mouth, it'll run its course. But when everybody starts speaking up and everybody starts saying something, that's when the change comes.
Yeah, CDC is an agency. Well, sure, let's get that in there. Let me just say that CDC is an agency that has supported all of our health for so long. This is a moment where we really need to support CDC and its employees.
Yes.
That's for sure. Well, thank you so much for coming up to Baltimore.
Thank you for having me.
And for talking to us about this. Please send the message to your employees that we're all here in support of them and the CDC.
Thank you, I appreciate it. Thanks, everybody.
And now, please turn your attention to the screens for a special message from the Governor of Maryland, Wes Moore. Thank you.
Welcome to the Bloomberg American Health Summit here in our great city of Baltimore. Now I'm proud to lead Maryland, especially at this extraordinary moment. Our state is home to hundreds of community organizations and health practitioners who are working to improve lives every day. Our research institutions pioneer new ways to cure and treat diseases, and our unique healthcare model helps to lower cost and incentivize prevention. We're seeing the results of this incredible work, from declining overdoses and homicides to better access to healthy food and progress in protecting our environment. Now, there's still more work that needs to get done, and that's why this summit matters. Because here you'll learn, you'll connect, you'll confront challenges, but you'll do it together. This is your time to collaborate on the work and to build a healthier world. Now, I hope you all have an incredible summit.
When I was younger, I planned to be a doctor or a sports psychologist, but then I discovered public health and realized I could work on the systems, the policies, and the conditions that help shape health for entire communities. Today, I have the privilege of serving as the CEO of the Louisiana Public Health Institute, where our mission is simple: to ensure everyone in our state has fair and just opportunities to be healthy and well. Living in New Orleans, I see every day how resilient communities can be. My own neighborhood, Broadmoor, was slated to be demolished after Hurricane Katrina almost 20 years ago. But residents organized, fought back, and rebuilt. That's what public health is all about: the community coming together to shape their future. Of course, the work is not easy. Advancing maternal and child health in Louisiana means working in a tough political climate. But one thing I've learned is that relationships matter. Walking into these rooms, I am often surprised to find that regardless of political ideology, we have a lot of the same goals. We just have different ways of addressing these goals. By focusing on building strong relationships with policymakers in our state, we have secured wins in unexpected places. From securing increased Medicaid reimbursement for maternal child health services to expanding doula coverage. I have seen firsthand when we come together to rebuild, we can create some incredible things. It is now my pleasure to introduce someone who has a lot of firsthand knowledge of building trust, fostering relationships, and securing policy wins. Michael Botticelli, the former director of the White House Office of the National Drug Control Policy for the Obama administration.
Well, hello, everybody. President Daniels, Dean Pollack, Parker, Josh, Michelle. You know, it really takes a lot to lure me away from pickleball these days. And yes, I have become that retired person who lives in Florida and wears nothing but t-shirts and flip-flops. But I was thrilled to accept this invitation to be with an institution and people whom I admire and have the utmost respect, admiration, and fondness. For some of you who have known me for a while now, you know that I am usually not someone who's at a loss for words. Quite the opposite. I'm usually exceedingly verbose, sometimes about things which I know very little. But I have to say, in preparing for this talk, I found myself struggling for what to say given the extraordinarily challenging environment we are in, yet simultaneously acknowledging and celebrating the progress we have made over the past few years, often spearheaded and supported by the very people in this room. As I reflected on this struggle, it felt entirely familiar to me. What folks who work with people in recovery and those of us who are in recovery know all too well is that recovery is not a linear process. It's not a straight line from sickness to wellness, from despair to hope, from isolation to community. Like life itself, it can be filled with extraordinary gains when you see how far you have come from where you've been, when you find beauty and gratitude in the world, when you find meaning and purpose in your life, when you feel a sense of belonging, connection to community. But there can also be very dark days when all you fear is despair and hopelessness and don't see a path ahead. When you get sick again and relapse, or when the best you can muster is to not drink and do drugs that day. When all you have to rely on is your community to hold you, to support you, and to tell you that they will carry you through these difficult times. For me, the principles and practices of recovery have always helped me not only to stay sober, but as a way of life to guide my thoughts and actions in every part of my life, particularly during difficult days. First things first, do the next right thing. You are not alone. Progress, not perfection. This too shall pass. All those slogans have served me well, and I think can be guideposts for all of us in the weeks and months ahead. While all of us understand how much work and the difficulties that lie ahead, I think we must also take time out to acknowledge and celebrate our collective achievements. After decades of year-on-year increases, overdose deaths are down dramatically over the past few years in almost every part of the country. Those reductions are driven in a large part by expanded access to treatment with medication, Medicaid coverage, and through expanded access to harm reduction services, particularly naloxone. States and local governments have received billions in additional service and research funding through federal grants and opioid settlement dollars. Policymakers finally have access to more timely and detailed overdose data. You know, I must tell you that throughout the entirety of my career dealing with this epidemic, both at the state and the national level, the best we could do was 2-year-old data. I liken it to driving a car down a highway at 90 miles an hour, and the only thing to guide you is a rearview mirror. This shows what we can do when leadership, resources driven by evidence and data can accomplish. And I want to pause to acknowledge Dr. Ingveld Olsen, who's here with us today, who was the director for the Center of Substance Abuse Treatment, I can't say that word, Ingveld, at HHS during the Biden administration, who drove many of these changes. We owe her a debt of gratitude. All of us hope that these and other efforts would continue, but we know that this is not the case. All of the progress that we have worked so hard to achieve is in serious jeopardy. Medicaid coverage is under fire. Services and research funding is being slashed. Harm reduction, which has become a dirty word again, funding and services are being halted at the federal and local levels. People with addiction and mental health issues and housing instability are being swept off the streets, many being subjected to cruel, ineffective, involuntary treatment. Make no mistake, all of these are outward manifestations of stigma at the policy and practice level. Perhaps most alarmingly is the wholesale abandonment and downright disdain for science, evidence, and data. This field has always undervalued science and research and has been plagued by what I call the I know a man guide to decision making, relying on anecdote rather than science and evidence. I know a guy who found recovery without medication, so let's ban medications from our program. I know a guy who got sober through his church. So let's slash treatment funding. These are not abstract concepts. These are real examples of some things I've heard from legislators and policymakers over the course of my career. So given all these threats, how might we move forward? How might we continue to try to make progress in this environment? So I have a few things I've learned over the course of my career. The first, practice harm reduction principles with politicians. Sounds kind of odd, I know. But rather than just building relationships with those who support our goals, try engaging and developing relationships with those who might not be in total sync and bring them along. One of the most surreal memories I have of my time at the White House was spending 2 days touring Kentucky with then Senator Majority Leader Mitch McConnell. No secret that there was not a lot of love between President Obama and Senator McConnell. We personally could not be more different in terms of background and politics. But ultimately, through that trip, we forged a strong relationship between our two offices, and it allowed us to move our agenda forward. So, and this is the hard part, without selling your soul, build relationships with those that may not support your work, and try to forge a strong working relationship. Next, continue to focus efforts at the state and local levels. While we might not be successful at the national level, great change happens from the ground up, and much of the action in policy and practice happens at the state and local levels. They are the learning laboratories for policy and practice innovation and can also be strong champions for change with their colleagues in other jurisdictions. And I'm sure you're going to hear some of that in the panel that's following me. They are also the proving grounds for future leadership. Clearly, one of the goals of the Bloomberg Initiative is to build and shape that future leadership, but we can also work more closely and in coalition with other national organizations like ASTO, NASADAD, NACO, ASAM, and others to promote best policy and practice. Next, find unlikely allies. There are no better messengers than those from whom you would least expect it. Cultivate them, promote them. There is no better example than I can think of than Lieutenant Patrick Glynn of the Quincy, Massachusetts Police Department. As an aside, those of you who are not from New England, it's not Quincy, it's Quincy. Some of you might be aware that in 2010, the Quincy Police Department was the first police department in the country to carry and administer naloxone. And just to be clear, even though I was the state director, I had nothing to do with it. It was a Quincy mother whose son had overdosed who badgered the chief of police to carry naloxone. It's the power of advocacy. Instead of arrests, officers began to count the number of people they rescued, becoming almost a competition on who could save the most lives. Lieutenant Glynn, seeing the results at the local level, went on to become a national promoter for police departments to carry naloxone. One of our strongest voices for naloxone came not from the public health community, but from the law enforcement community. Next, just like with people, sometimes the best you can do is minimize harm. I know this can sound rather defeatist, but it's not. It's a reality given the current landscape. Sometimes, and especially during times like this, finding ways to mitigate harm might be the best that we can hope for and the most we can achieve. Many of you here today assisted in the development of best practice strategies and documents, developed principles on how to maximize additional funding flowing to state and local entities. In unfortunately similar ways, we may be forced to think how we help those same folks with guidance on how to work through budget cuts, fewer people with Medicaid coverage, and less federal support in ways that minimize harm, and at the same time preserve necessary and critical infrastructure with which to build back. Next, be the leaders you hope we would have. In the absence of federal leadership or good leadership, it is incumbent on all of you to fill that gap and to be the counter-narrative of false and misleading information. Develop and promote sound, science-based strategies. Cultivate relationships with media sources to provide good information to the public. Write not just for publication, but letters to the editor and guest essays. Be not just great scientists and researchers, but great storytellers too. Nothing changes hearts and minds like someone's personal experience or their personal story. And in the absence of belief in science and evidence, it may be our most effective weapon. And finally, be gentle with yourselves and those around you and support one another during these times. This is difficult work, even in the best of circumstances. I applaud our colleagues who have stayed in federal service, who are still trying to do some good. They deserve some special love. So as we move through what is likely some very difficult times, I urge you to commit to treating yourself and those around you with kindness and compassion and gentleness. Continue to find beauty and hope. Practice gratitude on a daily basis. Support people and organizations who are still doing good in this world. And just like we say at the end of every 12-step meeting, things can and will get better. We only have to work for them. Thank you very much.
Please welcome Sarah Whaley, Executive Director of Overdose Response for the City of Baltimore, Nidhi Sachdeva, Director of Strategic Health and Opioid Initiatives of the North Carolina Association of County Commissioners, J.R. Westberg, Bloomberg Fellow and Opioid Response Coordinator at the Hennepin County Sheriff's Office. In conversation with Aneri Patani, Bloomberg Fellow and Senior Correspondent, KFF Health News.
Hi. Well, hello everyone. It's great to be here with you. We are here today to talk about opioid settlements. And just briefly, I know there are lots of you in the audience who know about this, who work with this. I know the folks up here eat, sleep, and breathe opioid settlements, but for those who don't, these are the settlements with companies that made and sold prescription opioid painkillers and were accused of fueling the overdose crisis. They are now paying more than $50 billion over nearly 2 decades, mostly going to state and local governments. And the governments are meant to turn around and use that money to invest in services and programs to address the addiction crisis. So it's a lot of money when we talk about, more than $50 billion. People say, that's a great opportunity, and it absolutely is. At the same time, as many of you know, it's not enough to solve the addiction overdose crisis. So I want to start off by asking you all, how do you target the money to make sure that it's being most effective in reaching the populations that need it most?
Yeah, so thanks, Aneri. I think you have to ask 2 questions. Is one, who in the community carries the highest burden of disease? And 2 is, where do we see the most opportunity for intervention? So in Hennepin County, which is the biggest county in Minnesota, like 1.3 million people, we decided to focus on really justice-involved individuals. So people coming into the Hennepin County Sheriff's Office in our custody, they have some of the highest rates of substance use disorder. Somewhere north of 60%. 80% have really acute mental health needs. And we have rates of chronic disease that are 4 to 5 times higher than the general population. So this is a really sick and ill group of people that are in dire need of care. So really focusing on interventions kind of behind the walls, looking at recovery, and kind of bringing in some of these public health strategies in the public safety landscape, working on some of these upstream issues. So I think that kind of targeted intervention not only improves the health of the individual, but also kind of serves a dual dividend of also fewer overdoses, reduction of recidivism rates, and then improvement in overall safety of the community.
Absolutely. Nidhi, what about you?
Yeah, I think when preparing for this panel, it was such an interesting juxtaposition because we've got, county level, state perspective, and city. And just this idea of being very honest about sort of what the landscape looks like within your state. In North Carolina, we have our North Carolina Memorandum of Agreement, which governs our settlement dollars in our state. 85% of our dollars go directly to local governments, which includes all 100 of our local counties, right? And we have mostly rural, and so we have to be really honest about what infrastructure exists within our counties and what we can build on. And I think we've done a really good job of trying to take a comprehensive approach and really featuring high opioid abatement strategies by pulling out strategies that we think are the most impactful. So we have sort of put at the top of the list access to medications for opioid use disorder, gold standard care. We know this stuff works. It's the cure for the leading cause of death for adults under the age of 50. Why do we not want to try to get this in all the possible places we can? And so how do we incorporate and integrate access to medications for opioid use disorder within our health departments that are already in all of our counties? How do we do our best to provide those services through community-based organizations like certain service programs or within our jails, understanding that this population is really, really highly impacted by many layers of challenges, right? And so we've been using really innovative approaches, including working with our EMS. Every county has an EMS service. And so how do we provide bridge programs and medications at the scene of an overdose, right? How do we offer that care and safety right there in that moment? And so that's been a really unique perspective in North Carolina. How do we just acknowledge and be honest about what we're working with here and then try to fill in the gaps where we can?
Right, so I'm hearing targeting folks who are incarcerated, targeting rural areas and working with the infrastructure that exists.
Yeah.
Sarah, you have a little bit of a unique situation in that Baltimore settlement, within the settlement agreement, had earmarks that the money should go to certain organizations. How do you work with those organizations to make sure that, the money had to go to them, but how are they still meeting the targeted populations that have the greatest need in the city?
Yeah, so Baltimore is a little bit different than the rest of the country because we didn't participate in the national settlement. So Baltimore pursued cases by themselves. And so we've won over $550 million for the city so far. And in those settlements, there were earmarked for $87 million for 22 organizations or programs across the city. And so you heard Dr. Taylor talk about the importance of data. And so the Baltimore City Health Department led on a citywide needs assessment, looking at both quantitative and qualitative data. So we were able to really see what the landscape looks like in the city. What are those populations that are most impacted? What are the geographic areas that are disproportionately impacted? And then we worked with each one of these organizations to talk about what they do really well, and how we can focus what they do into a scope of work that meets the needs that we're seeing in the city, and it can effectively and really purposefully use this money to fill in the gaps in service, to address the silos that we're seeing in care, to increase access to life-saving medication. We heard in the qualitative interviews that sometimes just having an ID was a barrier to getting MOUD. And so how do we work with these organizations and define a scope of work that addresses some of those issues?
Absolutely. So we all know right now there's a lot of political division. We've been talking about that at this summit, beyond. But the thing with the opioid settlements is we know the crisis is affecting all parts of the country, and the money is also arriving everywhere. Every county, every city almost is receiving some of this. So I'm hoping some of you can talk about how do you work with folks who have different political views, approach addiction in a different way. JR, you work within a law enforcement department. How do you talk about public health and public safety when it comes to this money?
Yeah, I mean, I think public safety is traditionally they focus on order and security and discipline and focus really on controlling the behavior of an individual, whereas public health is more about primary prevention, harm reduction, and I think more importantly, sort of patient or autonomy of care, and really and trying to tease out the underlying issues of that behavior. So sometimes those two ideas can come at odds, almost like a clash of cultures. So I think one of the things that I've tried to do is practice a harm reduction principle when speaking with public safety, sort of meeting them where they're at. And instead of starting the conversation off about a public health initiative that will improve the morbidity and mortality of people who use drugs, let's start with how this program can help you in your job, can make you safer, and thereby make the community that you work in safer. And then from there, you start to build out and introduce more kind of progressive, more public health related ideas. And the tagline I use all the time when talking to law enforcement partners is that a healthy community is a safe one, and a safe community is, by extension, a healthy one. So it's about finding that sort of common ground and then working out from there.
Love that. And Nithi, as you mentioned, you're working with a lot of rural areas in North Carolina, a lot of varied views, varied resources. What are the conversations you're having?
Yeah, I think we also have to be honest about how purple North Carolina actually is, given gerrymandering and all that. But so like each community isn't necessarily a broad spectrum of political beliefs. I mean, our purple spaces tend to be a city, a blue city within a red county, or just more urban counties tend to be bluer, and then the rest is a little bit more shades of red. And so I don't think we're actually that far away from each other. And I do believe that focusing in on sort of our shared humanity, the fact that at the highest peak, I think at most 11 people in North Carolina were dying every single day from drug overdose, that it was very easy for us to say, we all care about this issue. We all want our communities to be safe. We've all felt it in some way, and that, I think, sort of softens the conversation really quickly, because they're like, oh, yeah, you know, my son or my cousin or my neighbor or my friend or my, you know, classmate or whatever. And so I think it's more struggling with updating people's understanding of what the evidence is. It's like, well, when I was a kid, this is what I learned, but now we know more. And so how can we transition the conversation away from what was into what we know works better: harm reduction, evidence-based strategies, access to medications, and really just like going to the root causes. Right? Drug use is really a symptom of much deeper societal ills. And so how do we do our best to address the underlying root causes of that? Talk about housing, talk about employment, talk about meaningful connection with community, which I think is very relatable regardless of where you are on the political spectrum. And so just getting down to the stories, like it was said earlier today, is just how do we acknowledge the shared humanity? And we all don't want to feel pain. And in North Carolina, we've offered sort of a hope and vision for North Carolina that we hope that with the investments of the settlement, that all people in North Carolina will be healthy, that they'll be connected to supports and services within a culture of care. And most people are like, oh yeah, that sounds cool, sign me up for that. So that's been, I think, a really easy way to soften the conversation.
And then Sarah, it's always a little special with Baltimore. So I know Baltimore has certain ambitions with this money, such as an overdose prevention center, that are sort of at odds with the current federal administration and their views. How do you keep moving forward and work within that?
Yeah, so I think I feel really lucky to work for a city where we have an administration that is very supportive of evidence-based programming like overdose prevention centers, and even in a space where the federal administration or even some of our colleagues across the city are hesitant or unsure of those evidence-based programs. I think as we think about opioid settlement dollars and how we use them, the thing that we try to focus on and move forward with every day is the processes that we are building out. So no matter what we invest in, we have the processes and the data to show that we've made smart investments with our money and that they are working towards those shared goals that Nidhi talked about. And I think in Baltimore and across the country, we have to acknowledge that the reason we have this money is because people lost their lives. Families lost loved ones, and so we have to be good stewards of that money. And so really thinking about building out good processes, finding the data metrics to tell the story of what our investments are. And so no matter what we invest in, we're able to share that story publicly and really be good stewards of this money.
Absolutely. Well, I'm going to encourage anyone who is working on opioid settlements or interested to come and talk to these folks later. There's a lot more that we could discuss, but for now, thank you all for this great conversation. Really appreciate it. Thank you. So now we're going to turn to a discussion on harm reduction on tribal lands. So please join me in welcoming Kathy Shavers, former Bois Forte Tribe Chair, and the Honorable Philomena Quebec, Economic Development Coordinator for the Bad River Band of Lake Superior, Chippewa, and Chief Judge for the Sokogowan Chippewa Community Tribal Court. Nice to see you both again.
Yes, it's a pleasure. Thank you.
So we're here to talk about harm reduction, which is a term that has been around for ages and has gotten a lot more notoriety in recent years. And I've heard people define it in all sorts of different ways. I generally go with, it's a way of keeping people who are using drugs as safe and as healthy as possible. But I also think it's helpful to define it by giving examples. And so I want to start off by asking you both, can you share an example of a harm reduction strategy on tribal lands in tribal communities that has been successful? Philomena?
Go ahead, Philomena.
Oh, okay. Sure. So our program has very humble beginnings. And in the beginning, 10 years ago when we started, we didn't have any money, any building, or really much support from local public health. So we got a free phone number and some supplies from the Wisconsin AIDS Resource Center. And we started just doing deliveries, harm reduction deliveries, right? And we live in a rural area. We were covering much of Highway 2 in northern Wisconsin. It became a lot because we found that there was a really great need. And when we received operational funding, we changed this model to a paid contractor model. So we pay community members to deliver harm reduction supplies in a 4-county area. And they're paid by the data record that they produce. And that data record includes like just a lot of information about what happened, including a record on the number of overdoses that the person reported to them.
That's wonderful. The data collection kind of really shores up the intervention.
And it's seamless, right? So we know how to pay them, and we also receive this data, and they're paid for that data in a way that is consistent with harm reduction principles.
Absolutely. Kathy, what about you? What is a harm reduction intervention that you've seen be successful in your community?
Yes, we at Bois Forte are located in northern Minnesota, one road in, one road out. And we had the fortunate to have Dr. Melissa Walls and Sean Allen connected with our health facility. And tribes, we're very rural and very small. And we don't have opportunities to collaborate very often with organizations because we aren't aware of them or we don't know about them. And so Sean and Dr. Walls helped us get vending machines, public vending machines. We have the harm reduction machines. They're the first in the Minnesota tribal communities, and they have been very successful. We have 2 sectors of our reservation, and we put one in our Vermilion casino, and then in Net Lake, we put one in our convenience store, our C-store. That's the only store in the village. And so they're out of sight, so people have privacy. But in those vending machines are naloxone, fentanyl testing strips, socks, anything that people would want access to, HIV testing, pregnancy tests, and those machines are working great. We get monthly reports telling us which ones are the most popular and which ones are not being used, and then we can switch them out. It did take a while to get the machine because they're so big products not like a candy bar to come out of the machine. But they've been very successful, and we're very proud to have that because it has reduced our overdoses at Bois Forte because they do have that access to all those things that they need, because most of them are low income, homeless, some of them are homeless, and they just don't know where to access it. Transportation is a huge issue for Bois Forte. One road in, one road out. We're 65 miles from a major town. And so we need that there to help our people. So with that, that's what we have is our harm reduction machines. We're very, very pleased to have them.
That's excellent. And so both of you are clearly, champions of harm reduction. You're also both leaders in your communities. How have you used those leadership roles to champion harm reduction, to maybe talk to folks who don't agree with it or are not on board? How have your roles helped you make that change?
With Bois Forte, it's frustrating being a former tribal leader. And I worked in the healthcare industry for 30 plus years. And I get frustrated with politics, really. Even today, I sit back and I just shake my head because every day is different. We need our health. We need to protect our members. We need to make sure that we all have good lives and are healthy. And tribal councils are different. They are, like our tribal council is not really educated. Tribes are different when they have their elections, and it's really hard to explain, but we really like to have people come to the reservation to see us. One thing that I've tried to do as a tribal leader is to build those collaborations and partnerships, because we don't have the ability to do what we have. We don't have the data. Small tribes don't have data. We don't have the opportunities that the outside world has. And so we value anybody that comes to us and says, hey, I've got an idea. But remember, when you do that, make sure it's at the beginning of everything you think about, because as tribal leaders, sometimes we're asked, hey, what do you think about this? We've worked on this project for like 6 months now, and that doesn't work. You have to get the tribes involved from the beginning. If you have ideas, bring the tribes in at the beginning. They don't do that. They bring us in the middle or at the end and say, hey, we've got this great program. We don't get direct funding from our state agencies. We need direct funding. They include us in their counties. We don't get that funding. We're not local governments. We have to go to the legislature. We have to kick their shins once in a while to wake them up. People don't know about tribes because our history's never been told. They don't know that we're not a race. We have political status, special political status. We're not a race. Minnesota, we don't use the term BIPOC. We don't want to be included with that because we're a special political status. So with that, I just want to say, if you have an idea, come see us, because we're open to that. We have very small resources, small staff. We can't recruit. We're fighting the outside world. And we're also fighting our tribal councils to realize that healthcare is important, prevention is important. Thank you.
So as an attorney, I often see myself as bridging a lot of worlds, right? And there's many people who have, I visited with my tribal members who are pregnant in jail and experiencing real severe, intense trauma. And then I come before the tribal council and tell, like stories about what I've seen, right? And so oftentimes my leadership is related to bridging communities and translating those worlds. And what I try to do intentionally is to give away my political capital, because the people that I work for are people who use drugs, and they're often villainized. And it's really important to highlight their strengths, their leadership, and their stories in order to ensure that we have good public health strategies.
Absolutely. So just a few minutes left. I want to ask each of you if there's one sort of challenge and a critical resource that would help you address that challenge. I think, Philomena, you talked about the changing drug supply.
Yeah, I mean, what we've seen in the past 6 months is our overdose reversal reports going way down. So a 5-fold decrease in overdoses actually occurring in our local community. And in talking to our contractors, who include people who use drugs actively, what we found is that the drug supply has really reduced in potency in our local area. And so, that seems like a good thing, right? And we've seen many people much more interested in treatment. But what it has also resulted in is a migration to cities. And so many of the people who are at higher risk for overdose are no longer in our community. We can't take care of them. They're living on the street in Duluth. And this is very dangerous. We just had a tribal member suffer an incredibly life-threatening sepsis infection because she was out there and not coming back to us and getting like the community care that we can provide in Bad River. So having access to all forms of treatment, including methadone, is critical. We do not have that right now, and it's a major deficit.
With Boys Forge, or with us, the challenge is getting providers. We don't have counselors. We are an aging population in our workforce. We're fighting, I always say we're fighting, I'm sorry. We're challenged by the outside world because they have tons of money to recruit and retain people. We're 50 miles from the Canadian border, 60 miles from a major facility. And so a lot of people don't want to come to the rural areas. And that's a challenge. That's a very big challenge. We don't have access to treatment. If somebody wants to go to treatment today, I don't know if they'll find a bed. We don't have adolescent treatment. We have one in Minnesota. It's really sad. The need is great, but the access is not there. We need those facilities desperately because our people are dying. All people are dying. And we need to help in prevention. We need to get our elders involved. Our elders are caregivers also of these children, of the people that are suffering and out battling this addiction. So I just want to say that, you know, anything, I'm desperate here, anything anybody can do or have an idea, please talk to the tribes. We have the highest health disparities of anybody in the country. And why is that? Maybe because we're invisible. People don't think about Native Americans. They think about Caucasian, Asian, blacks. That's all you see on the data. So, miigwech.
Yeah, it sounds like the challenges are really severe, but there's also a lot of opportunity for relationship building and folks working together.
Yes, collaborations and partnerships work.
Okay. Well, thank you both so much for sharing your expertise today. We appreciate it.
Thank you.
I was lucky. As an 11-year-old middle school student in Oklahoma, I received age-appropriate sexual health education. Not everyone from my home state can say this. It was this experience that led me to not only develop a healthy understanding of my own body and a strong sense of autonomy, it also led me to seek out opportunities to positively influence my peers. Once in high school, I became a peer educator to teach younger students about healthy relationships and challenging unhealthy messages pushed by pop culture. At the time, I never thought I would make a career of it. But during the pandemic, I realized I wanted my work to do more. So I moved back home to Oklahoma and committed to helping young people access the education and resources that they deserve. Today, I serve as the Director of Programs for Honestly, the backbone organization in a collective impact model. We serve dozens of organizations across Oklahoma City, supporting educators, clinicians, and parents who all play a role in adolescent health. And yes, working in adolescent health in Oklahoma does come with challenges. But here's the truth. 82% of Oklahomans support teaching about birth control in schools, and 89% believe students should learn about healthy relationships and consent. Our job is to keep building networks and translating the benefits of public health into shared values and doing what we can with what we have. Through my work, I have found that taking the time to understand the reasons why someone holds the beliefs they do can be incredibly impactful as we attempt to work across party lines to build a better future for young people. My work has shown me that even in the most challenging environments, access to sexual health education is not only possible, it is already underway. Now, it is my honor to welcome someone who is working on the front lines to improve the lives of young people across our country, Lisa Lawson, President and CEO of the Annie E. Casey Foundation.
This is a bridge in Portugal that I walked across in 2021. I was in a group and I had a guide, and it was still absolutely terrifying. But when I took a moment to look around, it was absolutely mesmerizing. It was spectacular. What a view. That's kind of what adolescence is like, isn't it? It's a long bridge all of us have to travel to cross from childhood to adulthood. It's exciting and scary all at the same time. I certainly felt that way growing up in Atlanta. Don't laugh. I'm sure you look kind of awkward too as a teenager. I remember many of the things you see on this slide. My first part-time job at Macy's, going to the prom, high school graduation. But I also remember some things you don't see on this slide. Driving too fast in my Buick Skyhawk down the highway, drinking wine coolers with my friends after football games, you know, the typical teenage thrills. But all of those experiences and my loving parents made me who I am today. But not all kids are so lucky. There are 48 million adolescents on that bridge right now in the United States, and many don't have the supports that they need to cross successfully to adulthood. Using all we know about what's happening during this time of development would certainly help us serve them better. I learned about adolescent brain science at a meeting where our staff was teaching young people who'd been in foster care. They explained how the brain grows from the back to the front, and we're born with capability in our brains around things like blinking and breathing in the back. But it's during adolescence that the front part of the brain starts wiring up. Skills like judgment, planning, and impulse control, often called executive functioning, aren't finished until the mid-20s. This information changed how the teens saw themselves and how the child welfare workers supported them. It was also a huge aha moment for me. I was like, this is how people become adults. Sort of like toddlers learning how to walk. A little bit of stumbling and a little bit of success. I appreciated the perspective because I had a preteen at home, and it helped me see how powerful the science could be, both as a professional and as a parent. So when I became president of the Annie Casey Foundation, I decided to focus on improving the ways we serve adolescents in all of our work, from child welfare and juvenile justice to education and job training. And that focus became an effort called Thrive by 25. It's our commitment as an organization to ensure all young people who are ages 14 to 24 have the basics like food, housing, and health care, relationships with caring adults, multiple ways to get the skills they need to get a good job, opportunities to make money and learn how to manage it, and chances to lead in their lives and in their communities. These were the things that young people told us they needed most, especially those who were struggling. We can think about these essentials as really the cables that hold up that bridge I was talking about. And when we marry them with adolescent brain science, incredible things can happen. Let me give you 2 examples. First, the science tells us that young people learn best by doing, and their brains crave experiences in the real world, not just sitting in classrooms. So we're supporting an effort called the Partnership to Advance Youth Apprenticeship, or PIA. It provides high school students with paid work, new skills, and the chance to earn college credit, and it's getting great results. PIA has already prepared more than 2,400 high school students across the country for high-paying careers in fields like manufacturing, healthcare, and hospitality. And why is PIA so successful? It's because it uses the brain science. It reflects on how young people like to learn, and because it gives them money to meet their basic needs, new mentors, and a plan for the future. The second example I want to share is something called the Soul Family Framework. We know at this age, young people want to be leaders, but they still need the guidance of caring adults to help them make good decisions. Unfortunately, thousands of young people leave foster care every year without a permanent family. We wanted to change that. So we worked with the group of young people on this slide to create SOUL, which stands for Support, Opportunity, Unity, and Legal Relationships. It allows young people in foster care over the age of 16 to choose a circle of unrelated adults in their lives to be their legal guardians, maybe a mentor, a coach, and a neighbor, who work together like a family to help this young person navigate life. Foster youth designed the framework, and they advocated for it to become law in Kansas. Washington, D.C. is next. Soul Family has done more than just create a permanent family for these young people. It's shown what's possible when we allow young people to lead. PIA and SOUL are just some of the ways we're applying the science and equipping young people with the Thrive by 25 essentials. But there are many other ways that we could help our young people grow into the adults that they are meant to be and that our communities need. And the operative word in that sentence is we. The Casey Foundation can't do this work alone. It's going to take all of us. Families, employers, policymakers, nonprofits, we all need to think of ourselves as bridge builders. And you, as public health leaders, have a unique role. You know the science, you know how to bring people together to prevent and solve problems, and you're natural innovators. The stakes are really high. We have got to get 48 million young people across this bridge right now. Our future literally depends on it. That's why I wrote my new book, Thrive. It's to help change the narrative about adolescence and help more people see this as a critical window of opportunity. Our young people don't need the pessimism that we hear about them in the headlines every day. They need us to instill in them a sense of purpose and possibility in their lives. And this goal is worthy of our very best effort, because when we do our jobs well, young people cross into adulthood with strong support systems, sharper skills, broader perspective, and the confidence to know who they are and where they're going. I don't know about you, but for me, that's the very definition of what it means to thrive. Thank you.
Okay, so we're here to talk about restorative practice. I tried to define it. It's so difficult to do, but I gave it my best shot. Restorative practice can look and be implemented differently from one campus to another, but at its core, it centers on building community, developing healthy relationships built upon kindness, generosity of spirit, and repairing harm when conflicts happen. It's seen possibly as an alternative to traditional punishment, maybe even circumventing that school-to-prison pipeline. Restorative practice stems from traditional indigenous concepts around peacemaking, community building, conflict resolution, such as talking circles. And so we'll get right started. Tamar to start, then whoever would like to jump in. What are the most effective ways to implement restorative practices? What are the components of successful programs?
Thank you, and hi everyone. It's a pleasure to be here. So, students thrive, and we all thrive, really, when we feel safe and supported and valued, when we feel like we belong, and that's what restorative practices are really designed to do. So when you hear the term, you might be thinking about something that just happens after a student breaks a rule. You might think about restorative circles and mediation to repair harm that was done. And this is part of restorative practices, but really they are so much more than that. So really it's a whole school, trauma-informed approach to building relationships and positive communications between teachers and students, across students. And so what does that look like day to day? When it's done well, it looks like community circles in classrooms every day that build trust and community. It looks like teachers checking in with a student when they aren't sort of going with the program and sort of asking, what's going on with you? And trying to understand that. It looks like I statements, teaching students how to communicate and understand what they're feeling, and really resolving conflicts before it gets to the point where something really serious has occurred. So it's not just reactive, it's really promotive, preventive, and it's not piecemeal, it's holistic.
And it starts at the beginning of the day, right? It was kind of a coming together of children.
Exactly.
And so, Sarah, I was wondering, how do we make sure we include all student groups? We've got children who don't yet speak English in this country, many of them, more than 5 million in our public schools. We've got children who are members of the LGBTQ+ community. How do we make sure that that we serve the whole school when we implement these practices?
Yeah, I think that's a great question, and it really builds off of exactly what Tamar was just talking about. So I was talking with my colleague Elise Poss, who spent some time evaluating implementation of these programs in the state of Maryland. And one of the things we see, right, is that one of the things that can fall off are those preventative aspects of restorative practices. And when we don't do that, when we don't build that sense of belonging, kids who are already experiencing marginalization or might be more likely to be excluded or experience discrimination, that can be a real problem then for asking them to engage in these practices. So there's some research, for instance, that shows LGBTQ students in restorative practice schools report less sense of belonging than their peers. They report feeling less likely to feel heard or feel safe when we do these kind of restorative practices. And so that keeps students from being able to fully engage. And we have to think about the policy environment in a changing landscape where we have things like Don't Say Gay, or we have things like bans on critical race theory. And we see, for instance, when schools actually take an explicit anti-racist approach in their restorative justice, we actually are more likely than to see effectiveness in reducing the gaps in exclusionary discipline that we really hope to gain. So we have to think about all of our learners, whether that's ESL students who might need language supports and being able to access and be a part of these programs, or it's students that are experiencing bullying because of who they are, that then might be in a restorative conference, and that might be sort of problematic if we haven't addressed those underlying drivers in order to really promote a whole sense of belonging in the school to build these practices on.
Right, and I would argue it would be very difficult for our students who do not yet speak English or facing ICE raids at home in their communities, sometimes near their grounds that are close to them, to feel safe in any space. It's a very difficult thing to achieve. Senator Brooks, how do restorative practices exist alongside current models of discipline?
In tandem, yes. We're not going to deviate from some of the disciplinary actions that based on the infraction, but at the same time, we want to approach it from a different perspective. We want to use restorative first and foremost. Then we go ahead and engage whatever action that needs to be. I think when you create an environment, a culture of safety, and you've got kids buying in, making sure that everyone is being held accountable, and the goal is to make sure that there's not selective punishment. We want to do things to improve the overall environment and have the other kids become a part of that. And then you've got the team concept, and everybody is working and pulling in the same direction. So, and also along with the SROs, we want them to be a part of this concept as well. There could be some retraining there. And we don't want to look at it from a position of authority or threat. We want those SROs, and we want the kids to view them as allies, as opposed to people there who are trying to, as adversaries, I should say. So that's the overall concept. We want this community to feel part of, and we want to uplift all kids at the same time. Kids, teachers, the SROs, the administration, everybody is a part of this concept.
Okay, and what supportive legislation has been passed to make this a reality?
I'm glad you asked. Senate Bill 68, which was a bill that I introduced, and we changed the name from restorative concept to restorative practices. And a practice is something that we engage in, something that we do, and we want that particular part of the name to be a part of what the intention of the bill is. That, and as well, we want other schools to, it's enabling, so other schools can join in and pick up on this concept, like Baltimore City, Baltimore County, Montgomery County, and then see how drawing these circles has such a positive impact on all the kids. We want to reduce the amount of conflicts that are in the school. And if we think about it, the kids, the neurocortex doesn't fully develop until you're 25. So how do we expect kids to make rational decisions all the time when a lot of the adults are not, So we want to, so we don't want to give them the tools that they need to be able to how to engage in trying to resolve and making that whole environment a lot safer, not only for the kids, but for the teachers, the administration, and everybody that's involved.
Right, that element of safety is so important for everyone. Yes. And I would argue 25, we might want to boost that to maybe 45, I don't know.
Yeah.
Tamar, you have a couple minutes. Can you explain examples like this being applied? Where have you seen this successfully done and then perhaps blown up?
Yeah, well, first let me say I'm so excited that you spearheaded this legislation, that it was passed. I think it's going to make a real difference in Maryland and really be a game changer for a lot of students. And I will now put in a shameless plug for a policy package that my colleagues and I are developing with funding from the Bloomberg American Health Initiative. We are working in partnership with Zeke Cohen, Council President in Baltimore City, and the Trauma Informed Care Task Force. And the idea really is to help spur legislation changes like the one that recently happened in Maryland. So this toolkit will include model legislation language and best practices for delivering restorative practices or really making restorative schools. And also summarize key data to drive policy change. We really need this because close to 20 states still allow corporal punishment in schools. There's an estimated 70,000 students who are actually experiencing corporal punishment each year, and a majority of schools still use expulsion and exclusionary school discipline for minor infractions and student misbehaviors. And we know that these things are applied inequitably and they have really harmful effects. So we need this kind of legislation so we can really help our students thrive.
And part of it has to be we want to keep children in school, right? We don't want to send them home. And can any of you talk about that, the ability of this tool to be able to keep the kids engaged and in school and how valuable that is to their learning?
Yeah. When this kid is sent home instead of being in school, when we look at what the information or the teaching, the reason for that kid to be in school, all of that is lost. And then if that was going to help that child mitigate those challenges that he or she is experiencing, then by all means. But it's not. I mean, there's a detriment there for that child. So yes, we want to keep that kid in school. We want to teach them how to deal with situation. And we all have bad days, but how do we coalesce around that particular child and teach them how to meander those challenges that we all have to face from time to time, So the goal is to keep them there, teach them how to mitigate, and then move forward.
Okay. Anyone would like to have the last word? We have a little bit of time.
I think the only thing that I would add to this conversation, which is so great, is that I'm a global researcher, and so I always come to each problem with the thinking of culture and context. And so as we think about taking a practice that's shown effectiveness for these things and implementing it in a wide variety of schools, what are the cultural and contextual factors, right? So schools are implementing a lot of different programs, and those have the potential to be synergistic, but we have to support administrators to do that. And we're also talking about a shift in culture, right? Like as Tamara is talking about these schools that still have policies in place, there's a shift in how we think about discipline and how we think about the relationship between students and teachers and how we think about a lot of sort of aspects of hierarchy. And that might take ongoing support, coaching for teachers, coaching for administrators, ongoing supervision and monitoring we have to be willing to invest into.
All right, thank you. Thank you so much.
Yeah, I'd like to, one thing.
Of course.
Yeah, and one final thing. I don't know what % kids are of our present, but they're definitely 100% of our future. And we want to make sure we arm them with all the tools that we can to protect us properly.
Well said. Well said. Thank you. Okay.
Thank you.
Please welcome Wendy Cervantes, Director, Immigration and Immigrant Families at the Center for Law and Social Policy. in conversation with Dr. Chiara Alvarez, Bloomberg Assistant Professor of American Health at Johns Hopkins Bloomberg School of Public Health.
Wendy, thank you so much for joining us here today. We know that we have so many urgent policy priorities for immigrant youth. What are a few that you're focused on right now?
Well, let me just say, as someone who's worked at the intersection of immigration, children and youth and policy issues for well over 2 decades, and who did this work under the first Trump administration, I have never seen a policy agenda that so deeply and comprehensively undermines the health and well-being of children, youth, and families as the one I'm seeing unfold right now in this country. I mean, let's be clear, the systems that serve immigrant kids and families have always failed them and have always created barriers, but we are seeing the barriers exacerbated by the policies that are being implemented right now. In fact, the budget reconciliation bill that passed this past summer very specifically expands the restrictions, making it harder for even lawfully present immigrants, including refugees, to access basic health care and nutrition assistance. And that same budget reconciliation bill also quadrupled the budget of Immigration and Customs Enforcement to really turbocharge the mass deportation machine that we have seen taking over the entire country, kidnapping parents. And I mean, really, while all the policies are harmful, it's the immigration enforcement that creates this climate of constant fear and anxiety that makes it scary to go to the doctor or to go to school. And that for the families that it's directly impacting, it's creating long-term devastating consequences.
Thank you for that context. It's sobering, but it's so important to know over the course of those decades, knowing that we've had a challenge, a system that's never worked in the best way possible for immigrant families, but that we're now at a point where it's so much worse. And I think as a mental health clinician, that aspect of the systems being actively harmful, they're not just obstructing good health and development for adolescents, but they're actively harmful, actively creating fear, trauma, and we've heard, a great keynote about adolescent development and the importance, right, of these supportive environments for development. And I think what we're really seeing on the mental health side is how damaging it is for youth to have to live in this environment of acute fear, not just of deportation, but of actual violence, of family members or possibly themselves being separated and not knowing where people are.
Yeah, absolutely. And the rhetoric is also so harmful. It's hurtful to hear people, much less our leaders, labeling parents as criminals, telling someone to go back to your own country, especially when that person was born here, or maybe this is the only country they've ever known. And, it's really, our young people in particular are also having to give up on their own dreams in many cases. Like in Florida and Texas, there are policies, like they took away in-state tuition. So now being able to go to college is actually unaffordable now for many undocumented youth. And we are hearing parents making really difficult decisions, and in some cases choosing to leave their siblings in the care, the youngest children in the care of their oldest sibling. So we have immigrant youth, or in some cases they might be U.S. citizens, who are being delegated the responsibility, not only faced with the potential of losing a parent, but now having to forego college and figure out how to keep a job and raise young children.
And that's so important because here at the initiative, we focus so much on that transition to adulthood, on making that a positive transition. What are the resources youth need to survive? And we are really seeing that transition being halted or being changed dramatically, youth being expected to function as parents and also not be able to pursue their own dreams and goals. And I know we have fellows here from across the country, many of whom are working with families and working to figure out how to navigate this environment. You have so much experience working in large coalitions, really working towards progress in these areas. What are some things that you think we should be doing now?
Yeah, I've been fortunate to be able to build two really diverse coalitions, the Protecting Immigrant Families Coalition and the Children Thrive Action Network, both of which are made up of really diverse organizations, but also community-based organizations and service providers. And one has the mission of protecting access to healthcare for immigrant families, and the other is dedicated to children and immigrant families. And really what we've learned is that it's really important for people to see immigration as core to their mission, whether they're working on health justice, education justice, economic justice. And having these diverse networks allows us to get resources and information to providers and at the front line and community-based organizations that are working with immigrant families so that they can have some agency and some understanding of this rapidly changing policy environment and have the information they need to make the appropriate decisions for their families, and to engage young people in those decisions and to make sure that youth also get connected to the resources they need.
I love that as a closing message for us, the idea that immigration, supporting immigrant families, supporting immigrant youth can be part of the core mission of a range of organizations, and that bringing youth and individual voices to the forefront, community voices, is key to that success.
Absolutely. We all have a role to play.
Thank you so much for your work, and thank you for being here with us today.
Thanks for having me.
When I walk in a room of young people, I see so much energy and at the same time, so many unanswered questions. They want to know, where do I belong? How do I build relationships that feel safe and real? Is what I'm experiencing normal?
And I hear those questions too. But for individuals who don't fit expectations of heterosexuality or cisgender identity, especially in rural places, these questions can carry a different weight. Without affirming healthcare, the search for belonging can feel overwhelming. I've sat with young people who are exhausted, scared, and sometimes even hopeless.
Yeah, and that's why creating safe spaces matters. When we give young people space to talk openly, to learn that setting boundaries, asking questions, and respecting differences is not just okay, it's powerful. They light up. They realize they're not alone in figuring it out.
And in those moments, I've seen something shift. That flicker of hope comes back. It's not just about avoiding harm. It's about intentionally creating lives full of connection, acceptance, and possibility.
But it takes perseverance, for them and for us. The obstacles are real. Lack of resources, fear of being judged, voices telling them to stay quiet.
And yet they keep searching for answers, for community, for care. And that reminds us to keep showing up too.
Because every time a young person learns to trust and love themselves and respect others, they're building a foundation for a healthier and stronger future.
And when we, educators, mentors, neighbors, friends, stand beside them, we remind them they don't have to walk that journey alone.
And that's the message that we want to leave you with today. Young people already carry that spark.
Our job is to help them keep it burning, through hope, through connection, and through perseverance.
And so we are now excited to introduce the next panel of experts who do this work day in and day out. Dr. Erin Hager, professor at Johns Hopkins Bloomberg School of Public Health, Pennsylvania State Senator Nikhil Saval, Lisa Ratliff, Chief Executive Officer of Kaboom, and our moderator, Joe Napolitano, Senior Reporter at the 74.
So as we know, firstly, thank you all for being here. As we know, recess is essential for children's physical health, their social development, their emotional well-being, yet few states have formal policies requiring recess in schools. So Lisa, can you tell us about the state of recess in the United States? What states guarantee recess in schools?
Surprisingly, not as many as we need. Just to get us all grounded in the space of recess, it's the source of joy in childhood. We're not, right? So we know how important it is to just our well-being, to our learning and our development. And yet in the 50 states plus the District of Columbia, there's 26 states that have some type of something around recess. yet only 10 of them have policies that are either mandating recess or pieces of it where they're not withholding punishment or there's some criteria in place. Only 10 of the 50 plus DC.
Okay, so tell me the importance. How does recess kind of help a child maybe moderate their mood or their day?
Yeah, it's everything. You think about the responsibilities of childhood, the learning that has to take place, the socialization that has to take place, the pressure that they're under, the competition that they have with real life experiences versus living through their devices. Recess is the space where they find their belonging. It's the space where they learn. It's where they get their physical activity. You know, we've got the CDC recommending 60 minutes a day of physical activity. That's not happening. Recess policies are mandating anywhere between 20 minutes to 40 minutes, I think, in Arkansas has the highest mandate. Wow. Not even meeting the mandatory physical activity requirements or the having considerations for the learnings that happen through being outside with young people that are your age and learning in the same way that you do.
So Erin, what's the connection between recess, we had talked a little bit about physical activity and student well-being overall? Like how does it help a child really moderate and be present and able to learn?
Yeah, so we think about recess, we often think about physical activity as kind of our go-to. And of course, physical activity has lots of benefits for kids with respect to physical health, mental health. We know that kids who are active during the day do better on tests and have better academic outcomes. But recess is really interesting because it kind of falls at this intersection between physical activity and play. So I think of it as like a Venn diagram. And play, independent of physical activity, has its own benefits. So play is unstructured, it's social, and play has benefits with social interactiveness and peer interactions and academic outcomes on its own. And so I like to think that recess is like the best of both worlds. So by having kids engage in active play, they have those health benefits, mental health benefits, and it benefits learning, which is often most important for schools.
And they learn negotiation and compromise and all that fun stuff. Senator Isabel, I was wondering if you could talk about lessons from legislative efforts to protect recess time and address inequities in infrastructure.
Absolutely. So Pennsylvania is one of those states that unfortunately does not mandate recess time. There have been legislative efforts. Most recently in 2023, my colleague Rep. Danielle Friel-Otten introduced legislation that also paired recess with healthy nutrition. Unfortunately, that legislation didn't have a vote, didn't have a hearing. And so we have a sort of unequal landscape. Philadelphia, the city that I represent, there's also no mandates. There's sort of a lot that's left to the discretion of principals. But another issue that I think is related to that is the infrastructure for play. A lot of schools across Pennsylvania lack play space. Fundamentally, 1/3 of schools in Philadelphia do not have play space for recess. 1/3. Wow. This is one of the largest school districts in the country. Now that number is actually an improvement from 2018 when 2/3 of schools lacked such facilities. And we'll want to talk about those improvements. Now the legislature, state legislatures generally have a critical role to play. One, of course, is in creating those mandates. But what could be paired with mandates is an overall effort to provide play space. And Pennsylvania's legislature is right now involved in a critical funding effort. Funding is, of course, one of the main roles that legislatures play in school funding overall. And districts across Pennsylvania it's one of the most unequal states when it comes to state funding, such that a Commonwealth court, our appeals court in 2023, rendered our school funding system unconstitutional. So we're involved in a years-long effort, well overdue, to remedy inequalities among districts, which will help remedy broad infrastructural issues in our schools, including play space. That's just legislative efforts. I think there's also a critical role, of course, for advocates to play in this process. There's a group that I want to highlight in Philadelphia called Lift Every Voice, which is a parent-led advocacy group that has been campaigning recently for a joy-based budget for our school district. And they actually are trying to create a chief officer of joy. And the idea is to...
Can I apply for that job, please?
Yeah, this job's open. And the idea is, to pair the need and desire for play, among other sources of joy, with infrastructure planning. And I think there's a real idea that parents, of course, should be involved in the process of whatever goes on in terms of remedying infrastructure across our district. Finally, of course, there's, in addition to kind of broad-based funding, there's kind of project-by-project funding. I've been involved in particular efforts of that kind. I've helped secure money for a new play space in one of the schools in my district, which we're, of course, very proud of, looking forward to breaking ground on it. But it really took the effort of parents who, frankly, in this case, were better resourced than most parent groups in the district, had access to connections and activity and, even, pro bono architecture expertise in order to produce a plan that then they could leverage. It's great. It's by no means a solution. And so how can we replicate that model across a district with less well-resourced schools, less well-resourced parent groups, so that we don't run into creating more inequalities among districts among schools within a district.
And Lisa, I was wondering, can you build on the point about access to safe places to play?
Yeah, I appreciate what Senator Saval was describing. It gets to the center of the work that we do at Kaboom, which is really about making sure that we are addressing these inequities that we see in our systems, in our parks, in our cities, where you've got large parts of the population that don't have access to places to play within their communities or even their schools, where, at first thought you would think every school should have an outdoor space. And this is where recess policy works hand in hand with investments in infrastructure to make sure that we are looking at where are their needs. But we work closely with Baltimore City Public Schools, where over the past 10 years, we've been trying to support their commitment to a whole child approach and working across their schools that have a very similar situation in terms of access, not just in having play spaces, but in having quality play spaces. And so oftentimes there is access, but it's not the quality that is needed to have to serve the developmental needs of a child. And we've built 26 play spaces with them that has allowed us to start to move the needle, where we're looking at, like you've moved it from 2/3 to 1/3, over time able to solve the problem. We've got most of our cities, there's subsets of the cities where kids don't have a playground within 1 mile of where they live. They also don't have a play space within their schools. If they do, that play space oftentimes is very limited in its design in terms of what it can do. So maybe it might have a slide and a swing, or a swing that's broken, but it doesn't have the additional considerations for learning, like an outdoor classroom. It doesn't have considerations for how all different abilities learn and engage with outdoor space and other children. And so it gets a little bit complicated here, because the problem isn't just to mandate recess, it's also to make sure that we are investing in very solid, healthy infrastructure that is going to create the landscape to provide the benefits that play and play spaces and being outdoor can have for a child's development.
It kind of has me thinking about food deserts, but there's like a play desert, or many, many play deserts. There's no safe, engaging place for so many of the nation's children to really run around, be free, and be children.
Yeah, nothing at all. And oftentimes in a lot of these places that do even have recess policies, kids are going outside and they're playing on blacktops.
Right.
It's hot and there's nothing to do. They're having to use their little imaginations to make the most of it. And yet they are hoping to go back inside where it's cool and there's activities for them to do, because investments haven't been properly made in that outdoor space.
And to all of you, and perhaps starting in the end here, what are the role of parents, educators? Like, how can people come together to ensure, or try to ensure, that every child has an adequate place to be a kid?
Yeah, so actually something my team has been working on for the past year with funding from the Bloomberg American Health Initiative is a policy package for development and passage of state-level recess laws. So we know from prior research that states where they have a strong recess law in place, kids are more likely to have access to recess during the day. And as we heard from Lisa, only 10 states in the US have recess policies that are on the books and are strong. And so the policy package will have tools for community members, parents, and other advocates to work with their state legislatures to hopefully pass new recess laws. And we will be launching this policy package in December. So if you want to learn more, the different components will also be posted on the Bloomberg American Health Initiative website.
I'm wondering if you can tell us a little bit more, like what does an adequate play space look like, and what age child might that serve?
Me or
You sure? Anyone
sure.
who has the knowledge on it.
Adequate play space, I mean, really, we think about recess for both elementary and middle school students,
Okay.
and so it can really vary depending on the age of the child, the number of students in the school, and what those students need. So I think it does tend to be somewhat school-specific based on those things, what grades it serves and things like that. So.
Okay, anyone want to close out with their 30 seconds?
You know, one of the things that we've been talking about is the quality of play space. I mean, green play spaces are also, I think, a thing that we need to be looking forward to. You know, the Philadelphia Water Department has an initiative to help create green play spaces to capture excess rainfall, tree canopy. You know, it's not a coincidence that many of these schools, you know, are in less well-resourced schools or have blacktops or, you know, don't have play spaces that are adequate. But they need overall broad-based funding, and we don't want to create inequalities even within schools among which have green play spaces and which don't. So as we face the effects of climate change, you know, I hope that we invest considerably in that as well.
Okay, well, thank you so much. Thank you all.
After being denied the chance to give blood because of my sexual orientation, I worked to overturn the federal ban on gay men from giving blood. I learned from that experience that policies can cause harm, but it's also possible to change them. Later, while teaching middle school in Dallas, I saw students feel the impact of policies that were inequitable. I saw them feel the impact of gun violence. It pulled me back into advocacy too. So I joined the Student Demand Action program at Everytown for gun safety. Now, on our partnerships team, I focus on building bridges. From Mike Bloomberg's founding of Mayors Against Illegal Guns more than 20 years ago to today's million-strong movement, Everytown has always been about bringing people together. Gun violence can be prevented. Safer communities are possible, and it starts with one policy, one act of courage, and one partnership at a time. Now, it's my honor to introduce someone who embodies that courage, embodies partnerships, and all that we do, and leads this movement with clear eyes and a full heart. The Executive Director of Moms Demand Action, Angela Farrell Zabala.
Hello, everybody. Good morning, everybody. First, I want to thank you, Jay. Thank you so much for your leadership. It is such a pleasure to work with you, to see you as a leader in this important fight. It is such an honor to be here with you today. And today, I want to talk about something that we all feel deep in our bones, which is the need to be safe. The need to dance at a concert, get our groceries, pray in your house of worship, and even be in your own home without the fear of being shot and killed. It seems like it shouldn't be that difficult. It's a basic right. But we don't have that kind of freedom here in America. Gun violence, in all of its many ugly forms, touches every single corner of this country every single day. And it leaves entire communities left to grapple with that trauma. It's hard, y'all, to keep up with these headlines about gun violence and about all of the things happening in our world right now. Let's be honest. These are pretty tough times. People are feeling like they can't rely on the federal government to keep them safe. And it's easy to see what's happening in Washington and feel completely powerless. But the truth, which is sometimes difficult to believe, is that we are never powerless. While Congress and the White House attack our public safety, it is our communities that are stepping up. So what does that actually look like? I get this question all the time, and they say something like, Angela, I want to do something about this crisis, but I don't know how. I'm overwhelmed. Where do I start? Listen, I get it. I've organized my entire life, and it's hard to know where to begin. So here are some truths that I've picked up along the way. The first is that building power starts where you are. It's no magic trick, right where you are. Local action has never mattered more than it does right now. Y'all know that right here in Baltimore, we are seeing historic reductions in violent crime thanks to Mayor Scott's leadership. That's right. And it doesn't stop there. We're seeing real progress happening in state houses and city councils and school boards across this country. This legislative session alone, Rhode Island passed a historic assault weapons ban, y'all. Historic. They were working on that for over a decade. And Texas passed $2 million in its budget for funding community violence intervention programs. So important. Colorado tightened access to the weapons of war used in our country's deadliest mass shootings. Our movement is demanding stronger laws like assault weapons bans, like secure storage requirements, and protections for survivors of domestic violence. And when the gun lobby tries to pass bills that would make this crisis even deadlier, communities can rise up and defend that progress. Every single phone call, every letter, every testimony matters because it tells lawmakers that we're paying attention and we won't back down. Are y'all gonna back down? I know that's right. Every phone call, like I said, every letter, every testimony. The second, right now, we're embracing holistic solutions. Every second. I know how discouraging that it can be when your politicians don't have much political will to make change. Your work still matters because showing up for safety of your loved ones will always matter. Even when your legislators won't listen, your community is listening, and you're planting the seeds of change. And there's so much work to be done beyond just passing laws. Handing out gun locks and secure storage literature can stop unintentional shootings. Partnering with local organizations that connect people to housing, to food, to healthcare, that's violence prevention too. And normalizing conversations in your community about what safety really means, that's how culture shifts. These solutions might not make the headlines, but they make a difference, and that's what's important. Third is we want to invest in your relationships. So much of safety is about connection. Talking about gun safety, talking about mental health, talking about domestic violence, all of that can be life-saving. And it allows communities to build partnerships between local leaders, survivors, public health experts, faith leaders, law enforcement, veterans, doctors, students, and the list goes on. This ecosystem is the key to our success. And it's how Baltimore has become the safest it's been in 50 years, y'all. The safest it's been in 50 years. And it's how we all can find common ground in our movement. Because like I said, we all share this need to be safe. None of us want our loved ones to be shot and killed. So let's start there. That's where our movement grows. More than that, investing in our relationships is what keeps us sustainable. This is a marathon. We must sustain. So we all have a role to play, but no one No one has to do everything, and I had to learn that the hard way. No one has to do everything. We have to be able to lean on each other, and that's how we create something big, something strong enough to take on the gun lobby and protect that beautiful baby. Something strong enough to take on that gun lobby and a gun industry that profits off of our tragedies. But I can say this every chance I get. Gun violence, it's not inevitable. It is preventable, and our power to prevent it lies right here in this room, in our communities. And that's why you should never underestimate the ripple effect of just showing up. When you volunteer, when you speak out, when you support a neighbor through grief, or you stand beside a student at a march, you're sending a signal that this fight is not someone else's responsibility. It belongs to each and every one of us. No single action will solve this crisis, but taken together, these actions build a movement, and that movement is how we win. Every day, I think about people I've met who have lost their children, their partner, their best friend. I think about the students, including my own girls, who practice active shooter drills when they should be practicing for spelling tests. I think about the survivors who never give up, and they get up every single morning, and they choose to turn their pain into power. But then I think about rooms that I've been in, like this one, full of people who refuse to accept that this is just the way it is. That's what gives me hope. That's exactly what gives me hope. And so whatever drives you to fight for safety, keep that close and keep going. That's how the magic happens, y'all. We need you more than ever right now. So thank you so much for showing up today. Thank you for everything you do. I really appreciate you. Thank you.
Please welcome Randall L. Woodfin, Mayor of the City of Birmingham, Brandon M. Scott, Mayor of the City of Baltimore, in conversation with Jennifer Macia, Senior News Writer, The Trace.
Mayors, let's jump right in. The president has mentioned Baltimore as a city where he'd like to send troops for the purpose of fighting crime. But your city, Mayor Scott, is actually a success story. 5 years ago, when you took office, there were 335 homicides. Last year, there were 201. This past April, Baltimore set a record for fewest homicides in a single month. Now the city is on pace to record fewer than 140 homicides this year. That's less than half of what it is usually. It's usually about 300. But that didn't come easy. There isn't a one-and-done solution to reducing crime in Baltimore. Mayor Scott, you employ a public health approach to gun violence, which is a blend of planning, policing, data analysis, social outreach, and community violence intervention. It's a holistic, whole-of-government approach that's a much more nuanced solution than send in the troops. And most importantly, you followed the data. And the data told you things you didn't realize, like that shooters and the victims were older than you originally thought. And it wasn't the drug trade, but interpersonal conflict that's driving the violence. Tell us a little bit more about your signature policy, the group violence reduction strategy, and smart policing, and how data played a role in helping you land on these strategies.
No, thank you, and thank you everyone for being here. I think first I have to just remind everyone that I grew up young, poor, and black in Baltimore. And just fortunately or unfortunately, depending on how you look at it, I grew up at the time of the height of the war against drugs, the war on drugs, zero tolerance policing. In Baltimore, in my neighborhood in Park Heights, we call it breathing while black policing. Like if I walked outside, I could be set in handcuffs because they had determined that everybody that looked like me that was in this age range that lived in these places were the most likely to be the victim or perpetrator of violence. Well, and look at those years, for example, in 2004, they arrested nearly 100,000 people in a city of 600,000, and we still had 270-something homicides. Last year in Baltimore, we had 201, as you noted. We had about 15,000 arrests. Wow. Significantly fewer homicides with significantly fewer arrests, because the reality is it's never been about how many arrests a police department makes. It's about who you arrest, and that's what. And when we're doing GVRS, we're really, it's a focused deterrence model, but we're actually giving folks an opportunity. We do the data. We actually had to delay the start of GVRS because when we looked at the data, folks were screaming and yelling at me, you don't need to do this. It's going to be black men between the ages of 18 and 25. Wrong. It was actually black men around 30 plus, right? There were no organizations ready to work with that age of a population to help them if they wanted to change their life. So we had to stand that up. And when you, in GVRS, what we do is we actually give people a chance. They get a letter directly from me. I know who you are. I know what you do. I want you to stay alive. The only way that you're going to do that is you got to stop what you're doing. We're going to give you every chance. If you need housing, we'll help. If you need education, we'll help. If you need to be relocated, we'll help. But if you don't, we're going to remove you with law enforcement. It's a partnership between my office, my police department that works under my command, the state's attorney of Baltimore City, the attorney general of Maryland, and most importantly, the community partners, because those individuals that we go to are brought in by trusted community moral voice partners that are able to bring them in, to give them that hand up. And this isn't the first time Baltimore has tried this strategy. This is actually the third time. But the previous two didn't have the most important ingredients. One, the political will to continue, even though everyone thought this is the wrong way and they want you to go back to doing zero tolerance where it didn't work the first place. And two, there weren't the resources on the community side. It has to be a both and. We have to understand that gun violence is the nation's longest standing public health challenge, and police alone should have never been bearing the full burden of reducing it.
Right. Right. What type of partnership would you like to have ideally with the federal government instead of the National Guard? Where would federal resources better be spent? Just asking
Just
questions.
one day, I want to not talk about them. Not anytime soon. I think that we already know, and we've laid out, mayors have laid it out. If they truly wanted to help cities, one, they could restore all the grants to all the CVI and all the law enforcement and all the things that they cut. I want people to understand this. The largest defunding of policing and public safety, even from a law enforcement standpoint in this country, has happened under this current president, right? So everything else you hear is hyperbole. But they could ban Glock switches. They could ban assault rifles. They could outright ban ghost guns. They could remove the T. Hart Amendment that will allow my brother Mayor and I to actually know where the guns come from, right? Because it's illegal. Our police departments work at our command. They go out and recover all these guns. For me, 60% of them come from other states, and I'll just say those states don't vote the way Baltimore votes, right? But it's actually illegal for my police commissioner to tell me exactly where that gun comes from. They are protecting people who are trafficking weapons into cities. They are protecting gun stores like Hanover Armory that we in Baltimore sued and won the largest settlement ever with a gun store because they are purposely skirting the rules to put guns in the hands of people. That's how they could help us.
Yeah. Yep. Mayor Woodfin, this is personal for you. You lost your older brother to gun violence in 2012. You lost your nephew. He was shot and killed in 2017. A few weeks later, you were elected mayor, and suddenly you're in a position to do something about gun violence. When you came into office, you inherited a city that had historically responded to violence by relying heavily on police. You decided instead to focus on the root causes of violence. like inequality and poverty reduction. You established the Mayor's Office of Peace and Policy to focus on prevention and reducing recidivism. In 2019, Birmingham was among the first cities in the US to declare gun violence a public health crisis, a strategy that, like Baltimore, encourages a holistic approach to tackling the issue. But results do take time. 2024 was a deadly year, but then something remarkable happened. Homicides dropped 52% in the first half of this year. So tell us, what's working? Where are you seeing progress? What's moving the needle? And what are some outside-the-box strategies that you've employed in Birmingham, like concrete roadblocks, greening neighborhoods? Tell us more.
Well, good morning, everybody. Let me first thank Bloomberg Philanthropies and John Hopkins. Also want to just acknowledge your mayor, who is a national rock star. I got a chance to be on a panel with him last week, and the way he uplifts your community and your city is amazing. So, Brother Mayor, congrats on everything you're doing. Thank you, brother. I will say this to everybody in this room. In 2019, when we declared gun violence a public health crisis, it was one reason. It was what the mayor said. You can't approach this only from a policing zero tolerance standpoint. For us, we look at it as a toolbox, if you would, and a minimum of 3 tools are in this toolbox, and that's enforcement, prevention, and re-entry efforts. But this holistic approach from a public health crisis standpoint is quite simple. It is, how do you engage poverty issues, unemployment, education, and a litany of things I don't even have time to name related to addressing this issue. One of the most important partners for us was our actual Jefferson County Department of Health. We need your public health leader at the table when addressing gun violence, because you're going to get additional resources, 1. 2, they're going to give you a vantage point of how you should tackle this. So this comprehensive approach has allowed us 5 years later to get to the point where we can say, not just the first half, but now ending 3/4 of the year, we're at 53% reduction of homicides. So it's holding. Wow. And it's not just policing. What we do, as an example, is not just place-based, but there's a neighborhood called Eastlake. And what we found in this neighborhood was that there was a significant amount of walk-ups, drive-by shootings. And what we found was by the time the police got there, we couldn't identify who was doing all the shootings. But we also found in this historic neighborhood, there were so many entry-exit points. So all we did was decrease the number of entry-exit points into the neighborhood, but we did that in partnership with the residents. We went door to door. We had town hall meetings, neighborhood meetings. We received information online, just an amount of feedback from the residents. This program has been in existence for over a year, and this neighborhood has had a 40% reduction in gun violence, in trafficking, drugs, in shutting down the trap dope houses, as well as removing the blight. It's cutting the empty lots, going vertical with single family homes on some of these empty lots, as well as other things we're doing to invest holistically in the neighborhood, not just decreasing crime, but seeding in hope and opportunity as well.
Right. Right. Establishment Democrats, and this could be for either of you, seem to have a hard time owning the issue of public safety. What are you each doing in your leadership to counter this notion that Democrats cannot be effective at reducing crime?
Yeah, well, one, you have to ignore the noise. There are a lot of people talking. I'm gonna pass this question to my brother. My wife told me to choose peace today. She did. She told me to choose peace. But the truth is, we're doing the work. And we have real results. When you're at the local level as a mayor, you don't have time for performative politics. No. What we're doing is not political. We're actually governing. Governing means that you are solutions-based and you're focused on solving problems, protecting people. That means any and all type of solutions that actually work, we will try. What we know is that there are other people in other colors. Let's say tomato soup. And that went over some people's head, I'm sorry. It's performative politics, but we're focused on results. So brother, close that for me strong, because I know.
Well, my wife didn't tell me to choose peace today. And even if she did, I pretty much never do on this topic. But I think that when, for us, if you ask me, and they know because I tell them this all the time, Democrats keep losing this issue because they are talking about, they have the wrong people talking. If they wanted to win on this issue, the folks that should be out in front to talk about this issue are us, the mayors. We're the one that have to do the work. When someone gets shot, no one is calling their senator or congressman. And listen, everyone knows I love my congressman, right? But here in Baltimore, we're blessed. We know that. They know that. They know that the public safety strategy has to be led through the local government. But when you get on the highs in the Democratic Party, they want to anoint people to talk about something that they have absolutely no damn clue of what they're talking about. You can't win. If they want to win on these issues, they have to put the mayors in the forefront. And then also, you have to do what mayors have to do. We have to talk about this issue at the level of the people, not in hyperbole, not in academia, not in what actually is happening and what we're doing to resolve that. People want the information that way. If they want to keep and continue to lose on the effort, do what they have been doing. We're going to do what we have to do regardless, because we're the ones that have to make those phone calls when someone's son or daughter is never coming home. We're the ones that have to talk at those funerals. We're the ones that have to bury people that we know, right? We have to do that. We have to eulogize kids. We have to do that. And until you have lived that life, until you have had someone like I had, a mother tell me that a young man that was killed outside my high school, that young man told her he was going to look for me before the game. Wow. He was looking for me. Then you have no earthly idea of what it means to actually work and try to solve this issue.
Wow.
Yeah.
It says we're out of time. I would love to talk to you about this twice as long, but real quick, what is something you want people to know about crime in your city, something you think is not getting out there?
I guess I'll start that it's complicated, right? You don't, even though we have now 101 homicides, that's 101 too many for me, but it's also the lowest amount of homicides we've had through the 30th of September ever on recorded record, right? Like, that's the reality. But we have a long way to go. And I think what I want to get out is that we've made significant progress, but we have to sustain it. And sustaining it means that we have to stay the course. We have to ignore the noise, as my fabulous brother Mayor said. We have to continue to support the things that work. And for some folks, we have to understand that the success of what's happening in Baltimore is all of our success. And folks have to stop wanting to clamor and fight over, it should be all about me. This is the true definition of a we success, and we all should be happy in it.
Yeah, very quickly, two things. 75% of homicides that occur in the city of Birmingham are interpersonal conflict.
Yep.
Within that number, 45% occur where police cannot be inside of a home, inside of an apartment, or inside a vehicle. Within that information, the way we've been able to solve our homicides, we have an 82% clearance rate as of today.
Wow. That's very high. Just some context.
People, witnesses are coming forward, sharing information. We're getting beyond the no snitching culture.
Wow, and that's a very hard code to crack. So that's incredible progress. Mayor Woodfin, Mayor Scott, thank you so much for joining us today.
Thank you.
I started my career as a clinical psychologist working with individuals one-on-one. But when I became a suicide prevention trainer during my PhD, something shifted. I realized that if we want to save lives, we can't just respond after a crisis. We have to prevent it before it happens. That's when I pivoted to public health. Today, I am honored to co-lead the Commission on Suicide Prevention at Puerto Rico's Department of Health. Our wonderful team brings together experts in psychology, epidemiology, evaluation, and communications, all united around a single goal: to save lives. We train policymakers, empower community leaders, and ensure suicide data is accessible. At its heart, violence prevention is about equity, dignity, and the chance to live a full life. Every day, I see people from all walks of life working to transform pain into power, collectively building systems of hope. And now, a brief video highlighting a new strategy to prevent intimate partner violence in Baltimore. Take a look.
House of Ruth Maryland got involved in intervention work really at the request of the survivors that we serve. One of the things we've been saying for years is that engaging with partners who are abusive is in and of itself a victim service.
We have crisis lines for suicide prevention, general crisis, intimate partner violence victimization, of course, but we lack services to engage people who use abusive behavior. The Gateway to Change hotline is a 24-hour anonymous and confidential hotline that is dedicated to receive calls from people at risk of causing harm to an intimate partner. We are fortunate to have received funding from the Bloomberg American Health Initiative to carry out this work. It's really an innovative approach because our primary approach to intimate partner violence prevention has been harm reduction for survivors, which is crucial. There's a need to engage some of the root causes of violence, which is the behaviors of abusive partners. Through the Gateway to Change hotline, they're able to have a more free-flowing conversation in a way that makes them feel heard, allows them to talk about other factors within their life that might be contributing to their use of violence.
We know that the legal system isn't seen as a resource for all of the families we serve, and we wanted to create a path for people to engage in our services that was low barrier. And now this hotline is a way for people to reach out without engaging a police officer, maybe doing it in the privacy of their own home. When people access this new hotline, they're going to engage in services and get support for stressors in their lives, like unemployment, mental health support, substance misuse. We talk about change looking like honesty and accountability and a willingness to work on themselves.
I actually had a call from an individual recently who was calling the Gateway to Change line. And it was their first time actually ever talking about anything they had done to harm another person. They told me it made them feel safe to have this place where they could speak without being judged.
We've been getting phone calls from all different types of people. We've had people who are seeking help because they are worried about the way they're treating their families. We've had survivors reach out to ask what change looks like and what services are available for their abusive partner. We've had community partners reaching out to figure out how they can make appropriate referrals for people because they care about somebody who's causing harm in their family.
We're hoping that community agencies implement the Gateway to Change hotline. We're learning that people want to voluntarily engage in supportive services to take necessary steps to change.
I think this is really giving us the reach that we're looking for, in the sense we've always said everyone has a role to play in ending intimate partner violence.
Wow, right? Here we are in 2025. It surprises so many people to know that intimate partner violence is still an issue today, affecting over 1 in 3 women with health and economic and housing impact. We've learned since the Violence Against Women Act, we can't criminalize our way out of this. We really need the tools of public health. And it's incredible to see you really deliver this holy grail, which is creating an option for people that are at risk of perpetrating harm. And the video was amazing. I know it was so much harder than that. Tell us about some of the challenges in this work.
Thank you so much, Michelle. The hotline is one of several innovative approaches to addressing harm against women in intimate relationships that's taking place at House of Ruth, Maryland. And in developing the Gateway to Change hotline, we conducted a formative evaluation, which consisted of engaging a range of stakeholders through qualitative and quantitative research, developing a robust staff training protocol, and of course, making sure that we had evaluation and monitoring metrics in place. And we are thrilled since the implementation in April to have had a steady rate of calls. We received a call from a partner who had recently strangled their intimate partner, which in intimate partner violence research we know is an indicator of intimate partner homicide. This person found the hotline number through ChatGPT and reached out to the hotline at House of Ruth, Maryland. Some of our lessons learned in this work is that confidentiality begets trust. We had done our formative work and we knew that the hotline was mostly welcomed by staff, by survivors, by potential callers, and we were also amazed at the level of candor that we have received among the callers. We also recognize that meeting people where they are, taking a stage-based approach to violence perpetration work has been a missing aspect of our work in this space, and it has been beneficial in this regard. And also, as we know, in any public health approach, proper infrastructure. So I mentioned the staff training, the protocol, all of these pieces. We want people to know that you can't or you shouldn't implement a hotline like this overnight. There are pieces that have to be in place. And so we developed a readiness protocol, which is available on the website provided by the Bloomberg American Health Initiative. We invite folks to check that out. And we look forward to scaling up this effort. So next steps include an outcomes evaluation, assessing or evaluating the impact of the hotline among callers. Also increasing visibility, our marketing strategies, engaging additional community partners. One of the strengths of this hotline is that there is a strong referral pipeline. So when callers call in, they are referred out to supportive services that may help reduce their use of violence. And then technical assistance. We are available to organizations who might be interested in developing a hotline like this. So as we all know, engaging people at risk of causing harm to an intimate partner is really is one component. It's addressing the root of violence, and there is so much more work to be done to address violence against women, which is why I am deeply grateful for the work that you all do and are leading. Tiara, I know that you are doing amazing work in the sexual and reproductive health space regarding intimate partner violence. Do you mind sharing with us a little bit about your work?
Yeah, I'm happy to. I mean, we've seen a lot of promising results so far. We've been working with healthcare providers, clinical staff, even on the front line, in order to kind of respond to intimate partner violence among patients. We've seen those promising results that even though there was a little bit of a hesitation in the beginning from staff on how to actually implement these protocols, we've seen self-efficacy, their confidence to do these protocols increase over time. We've seen a lot of trust be built between patients and providers as well, which we know is critical for disclosing and intervening on partner violence. And so we're really excited that work has really been blossoming in Baltimore, and we're looking forward to seeing its impact just kind of grow, because we know that the healthcare sector can really be a solution for partner violence. And it's another reason why policy investment is really needed in order to kind of scale up this type of intervention. And I'll pass it to Michelle, who'll talk more about the policy landscape.
Oh, we are at such an important and exciting moment, I think, in this space, right? So, building these threads, we know that there's no one single solution. We've got to layer in prevention. We've got to layer in access to support services through the healthcare sector and beyond, scaling up our direct service providers and making sure that workforce is really ready and robust to handle the volume of all of this. And just in the past few years, the field has really coalesced around these multi-pronged priorities, generated that first national plan to strategize thoroughly across all of these aspects. And I think we're about to see just incredible movement from states and cities to really bring this into reality. Super.
I agree.
Yeah, over to you. So watch this space. It is so incredible to see this solution lens and the incredible work that you've been done. So thank you.
All right.
Please enjoy a brief break. Refreshments and restrooms may be found in the lobby to your left. This will be a brief break. Thank you all very much.
Thank you. All right.
Thank you. I'm so sorry. I thought you were doing the wrap up. I was like.
Welcome back to the Bloomberg American Health Summit. Please welcome Dr. Khadija Ferryman, faculty at Johns Hopkins Berman Institute of Bioethics, and assistant professor, Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health. Dr. Irene Dankwa-Mullen, Chief Health Officer at Marty Health and board member of Heron AI, in conversation with Dr. Elizabeth Stewart, Bloomberg Professor of American Health, Department of Biostatistics at Johns Hopkins Bloomberg School of Public Health.
Welcome back. Thank you all for coming back from the break. Really happy to be here with you all. And I feel like it can't be a symposium like this without some discussion of AI right now. So we're happy to have our 8 minutes on AI. And I think the thing I want to start with is we've already heard a bunch of themes today about data and evidence. And in some ways, AI isn't new to public health in that regard, like focus on data, computational tools. I think what's different is the scale and the potential scope. And I think when we think about AI, one of the two features that I might highlight right now, one is sort of this ability of computers to do what we think of as human reasoning. We'll come back to that. And then also the fact that it learns from itself. And I think that that is what makes it both powerful, but also have some potential pitfalls. So that's what we're hoping to really dig into today. But again, I want to sort of stress that at the heart of AI is data, and I think we'll be hearing again about sort of both what the good and bad aspects of that. We're going to hear some examples from our two panelists about the role of possible applications of AI in public health to just to kind of give some initial ideas. You know, I've within the School of Public Health at Hopkins, we have people working on TB screening in rural areas where AI is enabling mobile units to go and do screening and then provide point-of-care treatment for people who actually test positive, sort of in the field, much more automated than has been possible in the past. Another, you might have heard at previous summits about work on suicide risk prediction models within the White Mountain Apache tribe, and using that to identify people at risk and then intervene, and that led to reductions in suicidal behavior in those communities. So I think, again, there's a lot of promise, but we know that there's concerns about representativeness and this automated process, and sometimes that sort of black box nature. So we're going to, again, have a little bit of time to talk briefly about some of these checks and balances and ways to think. So let me turn first to Dr. Ferryman. So can you tell us a little bit more about some of the data inputs used to build AI tools and then the implications for their use in public health practice?
Yes, absolutely. So I'll give two examples. One example is the All of Us research program, which if you haven't heard of it, it's funded by the National Institutes of Health, and it's on track to be the largest research study ever in history. The goal is to enroll 1 million people in the United States in the All of Us research program. At this point, 850,000 people have been enrolled. And the All of Us research program, although technically not a public health program, because it is enrolling so many participants and there is so much data, right? We can learn a lot about population health and public health from the All of Us research program. And so there have been really great examples of research using AI with the All of Us research program data. So for example, researchers have used AI and machine learning to do things with All of Us data like predict weight gain, to predict uncontrolled diabetes, to predict glaucoma. And one thing I want to stress about the All of Us research program, not only is it a huge program and so there's big data, from the very beginning, the All of Us research program has been really intentional about enrolling a diverse set of participants, right? So the goal has really been to engage communities, populations who've been underrepresented in research in the past. So this makes it a really promising example of how AI can be used for population health, for public health, when there is data representativeness, when there's a diversity of participants. Now let me just follow up with one quick example that shows sort of the other side. So researchers, as Liz mentioned, have been using, public health researchers using AI to do things like predict disease onset, epidemics, things like that. So there was a recent study using large language models. You might know those as the chat GPT type things. So using a large language model to actually analyze tweets from people in various countries to see if tweets could be used to predict an infectious disease epidemic. And this large language model did really well. It actually did a really good job at predicting when there would be outbreaks of infectious disease, except when they looked at tweets from the country of Haiti in the Caribbean. And that is because Haitian Creole was not as well represented in the tweets in the data that the large language model was analyzing. So that's an example where when you have unrepresentative data, it leads to bias and it leads to these AI tools not working as well for public health and for our public health goals.
Thanks, and I think a nice reminder that some of the evaluation tools that you all have been learning are still going to be incredibly important to help us be able to study those sorts of issues and how they are or are not working. So Dr. Danko-Mullen, I know you work a lot with AI tools in practice. Can you give us a little bit of examples of successful implementation of AI in public health?
Yeah, sure, happy to. So I would start by saying that successful implementation of AI in public health really requires a strong data governance. It requires a modernized infrastructure, so a good, really robust data architecture. It requires a trained workforce. It also requires strategic collaborations with not just physicians or health professionals, but also with the community. And most important, it also requires an ethical framework to really detect fairness and transparency. So what I'll say is that there are no, what we have right now are not really good, fully scalable, stable success stories remain rare, especially in public health. And what we have are actually promising practices, right, that are being implemented in collaboration with health departments, in academia or public-private partnerships. And some examples are, epi surveillance that you mentioned, looking at outbreaks where they use social media, where you can also use environmental data. And so we have those kinds, epidemiologic and disease surveillance. There's also predictive modeling, where it's being used to sort of detect, looking at emergency room visits or looking at, environmental data so that they could, figure out where AI could, or an intervention in public health could make an impact. A lot of these really rely on quality data, and which is lacking, and so there is some sort of a deficit there. There's also successful models in predicting asthma outbreaks, so environmental data using geospatial modeling, that's also going on. And a fourth example I'll use is also digital health communication. There's NLP being used in chatbots to communicate health messages, but some of those data also miss the local nuance or cultural values being put in the data. So there are some promising practices, but I wouldn't, I think we're yet to get there where we would have successful AI implementation.
Great, thank you. I think we're unfortunately already out of time, but we can clearly lots that we can follow up in with future conversations and maybe even over lunch. So thank you so much for bringing your expertise to us today.
Yeah, thank you.
Please welcome Dr. Arlene T. Geronimus, Professor, Health Behavior and Health Equity at University of Michigan, and member of the National Academy of Medicine.
Good morning. Okay. At age 50, Jason Hargrove was a proud and reliable Detroit bus driver and a married father of 6. In early 2020, Mr. Hargrove's Facebook profile picture showed him on his bus wearing a face mask with the Detroit Public Transportation logo clearly visible on his hat. He wrote on the hashtags that surrounded his photo read @coronavirus, @I cannot stay home, @I'm on the road for you. Mr. Hargrove posted a video on March 21st, 2020, which he stepped off his bus to record, evidently in need of fresh air and cooling off, as we see him wiping sweat from his brow on this Michigan winter's day. He shares his fear and righteous consternation at the fact that a passenger on his bus coughed repeatedly without covering her mouth. He makes an effort to prevent those watching from writing him off as an angry black man by emphasizing his years of service and sacrifice. There's folks dying of this, he says into the camera, and I am trying to be the professional they want me to be. He assures his wife that when he comes home, he will take off his tainted uniform and put it in the wash and himself in the shower before uniting with his family. 4 days after making this video, Mr. Hargrove was diagnosed with COVID-19. Although he sought medical care, he was not admitted to the hospital. A week later, on April 1st, he died from complications of the disease. In March 2020, we were beginning to identify risk factors to inform triage as sick people overwhelmed hospital capacity. The clearest risk factor for death was being elderly. At 50, Mr. Hargrove didn't qualify. Indeed, on average, only 3 out of 100,000 50-year-old Americans diagnosed with COVID died of the infection. For Mr. Hargrove, as well as for many others in the Black and other marginalized communities, his underlying cause of death dates back centuries. Beginning long before COVID and echoing the tenacious civil rights activist Fannie Lou Hamer, young through middle-aged adults of color speak of being sick and tired, and they are right, physiologically as well as existentially. The chronic activation of measurable physiological stress processes in their bodies over years and decades shortens their healthy life expectancy and hastens their death. I coined the term weathering to name the structurally rooted physiological process of accelerated wear and tear throughout the body. Weathering is a measurable biopsychosocial process that leaves identifiable groups of Americans vulnerable to dying or suffering chronic disease and disability long before they are chronologically old. Through weathering, members of marginalized populations age prematurely, no matter how well they follow the social contract, the American creed, or the latest dispatches from the front lines of healthy behavioral science. As human beings, the inner workings of our bodies are always active and adapting, physiologically responding to environmental stimuli to keep us safe, whether from a raging beast, an objective environmental challenge such as sub-zero temperatures, or a threat to our social identity safety such as a racist aggression. Our neuroendocrinological wiring is exquisitely attuned to being alert for such danger, both consciously and unconsciously. Research in social psychology tells us that members of marginalized social identity groups enter new situations with uncertainty and become vigilant for cues indicating whether or not they belong, can trust others, may be in physical danger, can be authentic, or will be treated fairly. Such vigilance automatically activates the human physiological stress response, flooding our blood systems with stress hormones that mobilize sugars, fatty and amino acids out of storage sites for energy, and immune cells in anticipation of wounds. If we are able to evade the immediate danger or are reassured that it was a false alarm, the flood of stress hormones recedes and our body returns to baseline functioning in short order. This automatic process is protective when we are in an acute life or death situation and is also adaptive for other kinds of threats that are short-lived. However, our stress process stays activated when the stressors that trigger it appear repeatedly in our daily round, are prolonged, or remain unresolved. Randomized controlled trials consistently find that these types of biopsychosocial stressors can result in hours, even days, weeks, or months-long physiological arousal and reactivity sustained even while you sleep. In this predicament, over years and decades, any human being would experience cumulative stress-mediated wear and tear across their cardiovascular, metabolic, neuroendocrine, and immune systems. Those systems then become damaged, dysregulated, weakened, and eventually exhausted. Through this automatic and chronic process, populations subject to weathering pay a scientifically demonstrated health tax in the early onset of chronic disease, in unconscionably high rates of maternal and infant mortality, in depression and anxiety, in autoimmune diseases like lupus, in infectious disease, and in cancers. At the molecular level, cell aging, death, or senescence accelerates. Based on his likelihood of being weathered, Jason Hargrove's biological age at 50 would look more like an affluent white American's biological age at 70. Indeed, in those early days of the pandemic, 50-year-old Black Americans died from COVID-19 at the same rate as 70-year-old white Americans. Now, of course, everyone experiences stress sometimes, and even stress and coping that is prolonged. But how likely or deeply these experiences weather your body depends on your social position and opportunities for recovery, including the balance of time spent in settings where you can relax and release, instead of in places where you automatically remain vigilant and extend yourself beyond your physical or emotional limits to increase your chances of safety or success. In the current historical moment, there are reasons to expect weathering to expand to new groups and intensify in historical targets. For many Americans, our everyday world is objectively becoming more uncertain and threatening. Protections are being diminished, and opportunities for expressing ourselves freely are put on ice. From Latino immigrants to seasoned Black professionals to talk show hosts to school children, more and more of us need to keep our heads on a swivel to protect our lives and livelihoods, gain respect, or attempt to live unapologetically. As roving patrols of ICE agents now have license to show up unannounced and make arrests based on profiling, childhood vaccine mandates have been eviscerated, cancer and mRNA research defunded, jobs lost, housing unaffordable, and as climate change disasters loom, people's anxieties are multiple and sustained. Weathering adds to and interacts with socioeconomic, environmental, and lifestyle determinants of health to exert its pressure on morbidity and mortality. Weathering most deeply afflicts responsible, tenacious, hopeful, and loving members of the working or middle class, like the late Jason Hargrove. Short of action, weathering will remain the destiny of the marginalized, but it doesn't have to. When confronted with such clear inequity, we have to see what we can do about it. In addition to the other levers being recommended today, approaches to advance health equity must also address weathering, or they will fall short of their goals. Thank you.
My work at the Sanitation Facilities Construction Program within the Indian Health Service is about increasing access to critical public health infrastructure that improves the health of American Indians and Alaska Native tribes. This means coordinating with tribes and across federal agencies, nonprofits, academic institutions, and the Commission Corps of the United States Public Health Service to design and construct water, wastewater, and solid waste facilities. Thanks to the Infrastructure Investment and Jobs Act, we have an unprecedented opportunity, $3.5 billion, dedicated to improving sanitation facilities in Native communities. But money isn't the only resource needed to build infrastructure. We need partnerships too. I've seen the power of collaboration firsthand. We formed the Navajo Water Access Coordination Group, a group of over 20 partners working side by side with the Navajo Nation to increase access to safe drinking water for an estimated 30,000 people. In doing so, we are closing gaps in service for thousands of households without piped water connections across the Navajo Nation. Projects like these should remind everyone that health is not about access to clinical care, but is also about restoring dignity and well-being to communities that are often overlooked or undercounted. It's now my pleasure to introduce Dr. Samuel S. Martin, the director of the Johns Hopkins Institute for Planetary Health.
All right, well, thank you, and what a huge honor it is to get to be with you today and part of this just incredibly rich program. Over the course of, over the course of about 3 weeks last year, the New York Times broke two stories. The first showed that declining bat populations in the US were associated with rising infant mortality rates. The second showed that deaths in the US from hurricanes over the past century had been really dramatically underestimated. In the first study, a researcher showed that in counties where a fungal disease, white nose disease, had wiped out bat populations, that farmers responded by increasing pesticide use by 31%, presumably because the loss of bats had led to an increase in agricultural pests. He then noted that in those same counties, infant mortality rose by 8%, apparently because of the increased chemical exposures. The second study, 3 weeks later, showed that mortality from hurricanes in the US was dramatically higher than anyone had anticipated. From 1930 to 2015, there were 4 to 5 million excess deaths resulting from hurricanes. This number represents about 3 to 5% of all mortality in the continental US over that time period. And the number has been accelerating since 2001 in line with the increasing frequency of hurricanes resulting from climate change. These stories are part of a bigger story, the story of planetary health. The field of planetary health has really exploded over the last 10 years in recognition that the Earth crisis has become a global health and humanitarian crisis. Climate change, biodiversity loss, global pollution, and other environmental changes are degrading the foundational conditions for human health. The quality of air we breathe, the quality and quantity of food we can produce, our exposure to infectious diseases, our exposure to extreme weather events, and increasingly the habitability of many of the places that we live. As a result, we're seeing large burdens of disease across every dimension of health. In my own research, for example, I've found that rising concentrations of carbon dioxide in the atmosphere are making our food less nutritious and pushing hundreds of millions of people into the risks of nutritional insufficiency. We found that wild pollinator declines are causing about 500,000 deaths each year as a result of reduced production of the foods that protect us from heart disease, strokes, certain cancers, and diabetes. We found that changes in fisheries associated with ocean warming are putting nearly 1 billion people at risk for nutritional deficiencies, and that changes in land use in Indonesia are actually causing about 36,000 deaths every year from air pollution. These are just a few examples from my own research, but in an article that we published this summer in The Lancet, we showed that changes in any of the planetary boundaries that we use to track the stability of the Earth system have health impacts across every dimension of human health. So this is where we find ourselves. This is what Martin Luther King described as the fierce urgency of now. The way we have come to live is choking the life out of the planet. We as health practitioners are starting to sound the alarm that we can no longer effectively do our jobs. We can no longer safeguard human health into the future while the natural life support systems that we depend on are crumbling under the weight of our own collective ecological footprint. The good news is that there is a rich landscape of solutions to shift the way that we live across food and energy systems, manufacturing, and the built environment to bring humanity back into balance with our life support systems. Universities can be critical catalysts of that transformational change through our work in research, education, policy, and practice. And the role of the Johns Hopkins Institute for Planetary Health is to stimulate exactly that sort of transformational scholarship. In the American context, communications is, I think, a critical component. At the Institute for Planetary Health, for example, we've been thinking about the opportunity in the United States to train some of our most trusted messengers, nurses, physicians, public health practitioners, first responders, to respond rapidly to climate change disasters, to help communicate to the public the connections between climate change and their health and prosperity. As we sleepwalk toward the edge of a cliff, it's our responsibility in the health sciences to sound the alarm and help humanity move on to a different trajectory where we protect the natural life support systems that sustain us and the rest of life on Earth. Thank you.
Please welcome Dr. Bharat Jairam Venkat, Director of the UCLA Heat Lab, Dr. Ben Zaitchik, Morton K. Blotstein, Chair and Professor at Johns Hopkins University Kruger School of Arts and Sciences, in conversation with Zara Hirji, climate reporter at Bloomberg Green.
Well, thanks everyone for being here. We're going to continue the conversation on climate and health. And I'm really excited. We have two experts here, and we're going to really drill into kind of two specific pieces. One of the interesting things about climate is health is this is one of the ways in which climate can actually impact every single person in this room. But it doesn't impact people equally. So, Bharat, you do a lot of work with extreme heat. Can you tell us a little bit about who are the most vulnerable groups that your group is researching and why?
Yeah, that's a great question. So, when we talk about extreme heat, the negative effects of extreme heat are incredibly unequally distributed, right? We often talk about being in the same boat with climate change, but that boat is actually very large, but includes only some of us in particular ways, right? So what we do in my lab is we try to understand kind of what are the factors that contribute to making somebody vulnerable in particular ways, whether those be sociological, biological, the built environment, pharmaceutical even, right? So for example, we know that a lot of commonly used pharmaceutical drugs, whether those be for heart disease, for psychiatric conditions, actually impede our ability to stay cool, to thermoregulate. So for older populations that often take, 4, 5, 6 drugs every single day, they can really feel these impacts strenuously, right? And so as you get older, it's also harder to thermoregulate even without these drugs, right? So for older folks, that means that they're especially at risk of facing heat-related illness or even death. And you see this kind of trend not only in older populations, but say amongst the incarcerated, right? So if you're in jail, you already don't control your thermal environment. You don't have access to air conditioning. You might not have access to ice, to regular water, to showers. And you're also probably heavily medicated, right? So the American prison system is the largest purveyor of psychiatric drugs in the nation. And so those drugs are going to heighten your vulnerability to extreme heat.
So then following up on that, especially think about the incarcerated population you just mentioned, what can be done to actually help protect those people?
And this is a great question. I think it's really important that we understand that climate adaptation is also public health, right? And that can take forms that look really different than what we're accustomed to. So maybe that means, for example, fighting to have people be able to take different kinds of medications during heat waves to modulate how much they're taking or what kinds of drugs they're taking. Maybe it means pushing further and saying, well, if prisons can't keep people safe, we might get rid of them. We might, think about abolishing prisons, thinking about letting people free in order to kind of protect their lives, and thinking about that as a climate adaptation policy and as a public health policy.
Fascinating. I want to take a chance to bring Ben into the conversation. So separate from extreme heat, I know you've been really looking at how climate can impact diseases, specifically dengue. So can you give us a little bit of an explainer on how is this impacting that, and kind of again to what Bharat was talking about, who is then most vulnerable?
Yeah, thank you. And I think that the issue of vector-borne diseases, like so many health issues, remind us that global change is a multi-scale and complex problem. And so as Bharat indicated, there's a lot of very localized impacts that we see. But we also know that warming in the Arctic might be very relevant to South Florida, or might be relevant to Mauritius because of the way that we're interconnected in this. And when you talk about something like dengue or malaria, these kinds of diseases, you have heavily mediated processes where ecology comes into play, where human systems come into play. And so you might see something like, yes, a gradual warming trend, changing the range of Aedes aegypti, increasing the potential range of dengue. That's something we think about. But you also see extreme events. And so, for example, we look a lot at malaria in the Amazon. And 15 years ago, we were talking about eradicating malaria from the Western Hemisphere. And now we're in control mode because we've had floods, we've had droughts that have destabilized these human systems, land use change. And these are the kinds of impacts that we're seeing, which again just point to the complexity of these systems and our need to take a holistic approach to the various impacts that climate change is having on the most vulnerable.
So then, kind of similar to the question of Bharat, like what's being done about it, what can be done about it?
Yeah, and so we just heard Sam Myers talking about planetary health, right? And so I think that framing is just so vital. And when we talk about something like vector-borne disease as an example, Is that climate change? Yes. Is it many other systemic changes going on? Absolutely. And then when you talk about solutions, as we all said, as Sam was explaining, that we need to talk about the communication side of this, and that includes very much a two-way, three-way, four-way, many-way communication, because what we're dealing with here are problems that involve multiple stakeholders that are have multiple objectives, right? What are you trying to accomplish with your solution? And the only way to do that is through this kind of participatory wayfinding, right? So I think something that we've learned over the years, certainly in the climate realm, but I think environmental health more broadly, is that you can only get to solutions if you work in concert with communities, whether that means the affected community, people who are part of the solution, people who are perhaps part of the challenge, right? And we've actually had some luck on that right here in Baltimore. We've done a lot of work through the Baltimore Social Environmental Collaborative, which I lead, where we've worked really effectively with our partners in city government and communities and industry to say, okay, let's really define the problem. Then let's work together to see what kinds of pathways are available to us, realize we're wrong, argue, there have been more than one shouting matches in these engagements, right? And then come around to a point where we can say, okay, well, here is a messy but acceptable decision process that we can all engage in going forward. And I think that's gonna be true for so many of the wicked problems we face under global change.
Yeah, well, I'd be remiss if I didn't ask, just very quickly, you know, you're doing this work, the political environment has shifted. And so if there have been any examples that you can share about, has your work been impacted in any way, your ability to do this kind of research because of, say, a crackdown on grants or other things?
I mean, I can say briefly, personally, I had a National Science Foundation grant suspended, right? Luckily, it's back for now, but that impacts my ability to do this research. I think federally, we're all watching the endangerment finding come under attack, which is the kind of basis for regulating carbon emissions across this country. So there's a lot to keep our eyes on.
Yeah, and we've had several projects defunded, which is a huge challenge, obviously. In some ways, it accelerates the timeline of translational research. We always said that we were going to be able to make this self-sustaining. Now we have to do it faster. I have to say, going forward, I'm very concerned about us protecting our translational research. I'm also becoming increasingly concerned about the fundamental research. In some ways, making sure that our society values that fundamental discovery might be the bigger challenge, as we also try to protect the translational work that I think people do value and will come around to support.
Well, thank you so much. This has been a great discussion, and really, let's give a round of applause for Ben and Bharat.
Thank you.
Thank you.
Thank you.
So I'm really excited. We're going to have another session soon. But just to sort of recap, I know one of the things that stuck with me was both about how extreme heat can impact certain populations like the elderly. I know in my reporting kind of blew my mind that the elderly can kind of, their impact to feel heat can change, and learning about how medicine can actually have a similar effect. But I want to welcome to the stage for our next conversation on urban sprawl an expert on the field. Her name is Dr. Shima Hamidi, and she is an expert in this, she is an assistant professor and researcher at the Bloomberg School of Public Health at Johns Hopkins. Hello.
Hello.
All right, I think we should start with the basics. Do you think you could give us a definition of urban sprawl and maybe an example or two of a place that has a lot of sprawl versus a little sprawl?
Absolutely. Imagine you are living in the city of Boston, Manhattan, or in San Francisco. You get off your house, you leave your house, and you have dozens of destinations to go. You can walk everywhere. You can go to a restaurant, socialize with people, have an enjoyable, nice walking or biking, go to a coffee shop. 10 or 15 minutes walk and you are in a train station and you can go to your job. You are well connected to everyone and everything. And that's what most developed countries are building, how they are building their cities and neighborhoods. On the other side of the spectrum, a suburban typical neighborhood in the US, which most of us have lived and have experienced. You are living in a place that has nothing but single family detached. no other destinations, no other uses, all cul-de-sac roads, no opportunities for walking and biking. You have no choice but to drive everywhere, drive long distances, drive frequently, and being in congestion all the time. And that's what is the typical definition of sprawl, and that's what the US built environment and cities are mostly have been dominated by. And you see a huge difference in these two types of development and their health and quality of life outcomes.
Yeah, so I wanted to ask about that. You had also briefly mentioned like the 10 to 15 minutes. I'm sure people have heard this buzz term of 15-minute cities. I mean, it's part of the culture wars. And so when you're thinking about health outcomes on this spectrum of little sprawl to lot sprawl, is one considered healthier, or what are the ways in which you're measuring and tracking that, and what could be done to address it?
Great question, Zara. In suburban areas, as I mentioned, you have to drive everywhere. And that means less opportunities for walking, biking, and physical activity, more likelihood of obesity, which is like what 43% of American adults are dealing with. And all the chronic diseases that are coming with that, like high blood pressure, diabetes, cancer, heart disease, coronary heart disease. And that's not because we don't want to be active. It's just we don't have neighborhoods that help us to be active. Long driving and frequent driving means more likelihood of crashes, and higher speed of driving means more likelihood of being in a severe and fatal crash. 3.5 times higher likelihood of being in a fatal crash in sprawling areas. And if you look at the crashes, it's a leading cause of death for people aged 15 to 65. Less access to opportunities, healthy food, more likelihood of being located in a food desert, also mental health. More driving means more isolation. You kind of trapped in your neighborhoods, not really much opportunities for socializing, and more likelihood of depression. It's not only about our health, but also our environment. More driving means higher rates of greenhouse gas emissions, hotter summers, and more frequent extreme weather events, and all of that means more health-related, heat-related health outcomes. If you combine all of this together, living in a more compact or more sprawling neighborhood means on average about 3.5 years of difference in life expectancy, which is huge, because according to CDC, if there were a cure for cancer, the improvement in life expectancy would have been about 3 years. And we can do that through changing our neighborhoods and cities. The second part of your question, Zara, how we can do it? Through zoning reform. We should stop zoning and building exclusionary, only single family detached. I don't know if you know, but our cities won't allow other types of development in neighborhoods. And that has been, you've heard about not in my backyard, kind of causes that is associated with that. We have to change that. We have to go through zoning reforms and create neighborhoods that are inclusionary, that allow us to build everything connected, people next to each other, people next to destinations. And we have good examples of that, like Minneapolis or Tacoma in Washington, which one of our fellows actually have been helping with their zoning reform, Judy Olson.
And I know that Judy and you are going to be available to kind of talk about this stuff more. I really appreciate you taking the time, and please, thank you, everyone. And you can find our experts out in the hall if you want to ask more questions. Thank you.
At Northern Nevada Public Health, we've reorganized around the foundational public health services model, creating a structure that can contract when resources are tight and expand when new opportunities arise. We're fostering a culture of resilience, adaptability, and innovation. In these uncertain times, information is the currency of the moment, something we must invest in. We have prioritized keeping our staff and community informed with accurate updates and leveraging the media to our benefit. This approach has helped us navigate the complexities of our current environment and maintain trust and confidence among our most important audiences. I am proud to share that even in the midst of uncertainty and local deficits, we secured an increase to our tax transfer this year, the only Nevada County Public Health District to do so. Why? Because we kept showing up, inviting everyone to the table, even those who didn't agree with us, and making the case that public health isn't optional, it's essential. Public health has always been asked to do more with less, and to do it quietly. But this moment is a chance to change that, to stand up, to advocate boldly, correctly address state and local funding, and to tell our story in a way that sustainably resonates with everyone. It is now my honor to introduce a staunch advocate for public health and the environment, who has made a career in making the most out of a little, Dr. Matthew Tejada, Senior Vice President of Environmental Health at the Natural Resources Defense Council, in conversation with Joanne Kennan, journalist in residence at the Johns Hopkins Bloomberg School of Public Health and contributing writer at Political Magazine.
We began the summit this morning hearing from Baltimore's new health commissioner, Dr. Taylor, and she talked about getting data in the hands of the community and the power that can have. What you've been doing with NRDC is helping communities gather and collect data and own it themselves. Sure. We don't have a lot of time. I want you to talk really briefly about what that means, like data to the people, and then talk about two communities that are acting to make their communities more environmentally sound. One in progress and one a success story, because I think everybody here needs a success story.
Yeah, so I mean, one of the things I first learned when I started coming up doing this work in Houston, we're going to talk about Houston in a minute, is that there really isn't a whole lot of data about actual environmental conditions on the ground, especially when you were talking about the communities that have the greatest environmental risks, the greatest pollution challenges, communities that have been most marginalized over time. We really don't actually understand what is happening in those communities. Luckily, with the increase in technology, the affordability of sensors, the reliability of the sort of data that comes out of those sensors, we have a real opportunity at a time when our democracy is being attacked on an hourly basis to democratize environmental health protection by taking advantage of these low-cost sensors and the interest across the board from community advocates, from public health researchers at academic institutions, from state and local governments, to actually start putting those sorts of environmental monitors and sensors out on the ground across communities, and really from the ground up have communities generating the data, owning the data, and then using the data with their partners, with organizations like the Natural Resources Defense Council, to really make informed decisions about the places with the greatest pollution risks and the sort of interventions that are most effective at improving health conditions in those communities.
So what's going on in Houston? A hugely polluted petrochemical,
Right. You told me you were reading about Houston last night and you were a little scared.
I read about it before, but I reviewed it, yeah.
I mean, that was one of the things in Houston, like going back, again, to when I was first starting out as an environmental health and justice advocate there, just realizing that we had these huge pollution challenges all over the Houston region. And even though Houston would regularly tout itself as one of the most monitored parts of the United States, you really didn't know that much. And especially, again, in those communities that were right up against the refineries, right up against the ports, right up against metal shredders or concrete crushers, you didn't know what the health impacts were in those communities. So we started using community monitoring decades ago in the Houston area. Everything from getting a new ozone monitor put in the place that the models showed actually had some of the worst ozone in the entire region, didn't have an ozone monitor there, so we actually forced the state to work with the county to put an ozone monitor in there using our own low-cost sensors to kind of prove that the models were right, all the way up to using information we got about toxic chemicals around refineries when we would comment into, federal rulemaking processes, down to, what Air Alliance Houston, my former organization that's still down there kicking butt, is doing today, is using those sorts of low-cost monitors and sensors to really characterize the threats from things like a mobile batch concrete crushing facility that will go from community to community, to really get local city council members and mayors to understand with their public health departments just how big of a threat those small sources of pollution are for people that live right around them.
These are mostly poor minority communities.
Tend to be communities of color, working class communities, lower income communities, communities that don't otherwise have a voice, or even when they use their voice, aren't listened to. And when they can show up in a city hall or in a state capitol or just at the public health department saying, no, my baby's sick, I feel horrible, I smell it all the time, I can see it when I wake up in the morning and I take the film off my car, and here's a report from a monitor that we put up, that can really help be that straw that breaks the camel's back in terms of actually getting public health officials or elected officials to take them seriously, to hear and understand, because now you have a piece of scientific data that the community trusts because they made it themselves, and they are confronting experts who lack that data with information that is filling in the picture for them.
Okay, we don't have a lot of time. Just 3 sentences on the big win in Buffalo.
Sure. So another one of the big wins in my experience when I was at EPA running the environmental justice program was a really great environmental justice organization up in Western New York, Push Buffalo. They had many communities that were regularly being impacted by really dirty, really harmful pollution from a coking facility. If you don't know what a coking facility is, one of the most dangerous forms of pollution out there. So they started putting up their own monitors around this coking facility, and after years of effort and years of fighting for it, they convinced both the state of New York to work with the Environmental Protection Agency to really get that coking facility and their emissions in hand, and led to the closure of that facility that never should have been located in a place like the community of Tonawanda right outside Buffalo.
Unfortunately, that's all the time we have, but he's ending on a win.
When I tell people I work with data, they often imagine spreadsheets and charts. And yes, I spend a lot of time crunching numbers and running analyses. But here's the truth. Data are stories, and it's my job to help communities in Michigan tell theirs. At the Michigan Fitness Foundation, I work with a team to evaluate 2 programs funded by the USDA, SNAP Education and the Gus Schumacher Nutrition Incentive Program. Together, these programs give families the tools they need to stretch their food dollars and access healthy food. One of my favorite examples of these programs in action is the Michigan Farm to Family CSA program. Families using SNAP benefits can purchase fresh, local produce boxes at a reduced cost, and we pair that with nutrition education so they know how to prepare and enjoy what's inside. In one of our focus groups, a participant told me that without this program, they simply couldn't afford vegetables for their family. That's the kind of data that really keeps me going. Right now, public health is at a crossroads. Food and nutrition policies are shifting, resources are stretched, and communities are being asked to do more with less. At the Michigan Fitness Foundation, we're leaning in, helping local organizations build the capacity to lead, innovate, and create solutions that truly fit the needs of their communities. This is not business as usual. And that's exactly why we need to keep telling stories, to show that these programs really work, to secure continued investment, and to inspire tangible change for communities in need. I am now honored to introduce 4 people who certainly understand the importance of data. Crystal Fitzsimons, president of the Food Research and Action Center, Dr. Erica Pon, Director and State Public Health Officer for the California Department of Public Health, Bloomberg Fellow Ali Wolgamith, and Maddie Gelman, food reporter for the Baltimore Banner.
Hi, okay, so we know that healthy, accessible school lunches can be a lifeline
for food insecure, low-income families. And we also know from studies that it can improve childhood health outcomes, school attendance, and even test scores. So I would love to direct the first question to Crystal. Maybe you could talk a little bit about the exciting things that are happening with childhood nutrition to make sure that students are getting fed.
Absolutely. Well, I have to say one of the most exciting things that are happening in school meals right now is the movement around healthy school meals for all. And it really is a win-win for schools, for parents, and for kids. Healthy school meals for all is when schools offer breakfast and lunch to all kids at no charge. And it ensures that kids have the nutrition they need to focus and concentrate and learn in schools. It eases the household food budgets for parents. They can count on school breakfast and lunch 180 days out of the year, and it helps them make ends meet. And schools can count on having students who are well-nourished and ready to learn, and it reduces administrative work for the schools. During the pandemic, we had a trial run of healthy school meals for all, and a lot of people decided they did not want to go back to the way the school nutrition programs operated before. So we actually now have 9 states that have healthy school meals for all policies. We have 20 states that have legislation, or more than 20, to try and move in that direction. And actually, with the federal options and those state policies, we have 60% of schools offering free meals to all students. So I'm really proud at FRAC that FRAC helps lead the National Healthy School Meals for All Coalition, which is working to try and make this a reality nationwide, and then also working to protect the gains that we've made so that the current administration and Congress don't roll that back. And also really excited that we get to work with a lot of state campaigns who are leading these efforts, and it's a lot of really amazing organizations that are doing it. And the other thing, breakfast is an amazing option as well, but participation really does lag behind lunch. And so we are very focused on strategies to increase breakfast participation because the way that most schools operate the school breakfast program, they do it before the kids are even at school. So breakfast after the bell, breakfast in the classroom, grab-and-go breakfast are all really important strategies, and local communities can implement them. So even at a point in time when there are a lot of negative things happening with the federal nutrition programs, I am very heartened by what's happening with school meals.
And Dr. Erica Pan, there's so much that California is doing, from trying to ban ultra-processed foods by 2035 to now the universal school lunch program. Can you talk a little bit about what other innovative strategies the state is taking to feed their students?
Sure, I'm happy to talk a little bit more about one program we're really proud of called Farm to School. This has been championed by our first partner and working with our farms and our Department of Food and Agriculture. And these are grant programs that really connect local farmers with schools within a certain radius to provide that fresh farm to school, first school lunches, and also really provides hands-on education in the classroom to learn about agriculture and food and nutrition. And this is now in half of the schools in California.
It's amazing. That's really exciting. And Allie, I know you've worked a lot in California, in the Bay Area, with schools, with advocates. You are trying to educate people about the policies that they can take advantage of to make sure that their students get fed. Can you talk a little bit about what you're seeing with schools and what policies they can take advantage of?
Absolutely. Fortunately, out in California, we do have healthy school meals for all, right? But there are still places where schools can do a better job implementing these policies that we have in place. I think one of the really cool policies that California has had passed for the last 3 years is that schools, elementary schools in particular, can provide free breakfast to the siblings of low-income students. So 2, 3, 4-year-old siblings can be getting breakfast at schools, but we haven't seen a wide uptake of this particular policy. And I think that's a huge way for schools right now, particularly with SNAP cuts, to support our low-income families.
That's really exciting. Are there certain areas where you're seeing a lack of education in schools over, certain partnerships or things that they can do to feed their student? I know you were talking a little bit about how a lot of your work is educating on what else they can do.
Yeah, absolutely. I think it's tricky, right? Policy changes all the time. And there's a real need for us as public health advocates to sort of bridge the policy piece and what's going on the ground so that schools are able to better implement these policies. When I was doing my research, I found that about 50% of after-school programs and school lunch programs are not allowing kids to leave the school lunchroom with non-perishable foods, despite the fact that this has been encouraged by the USDA since 2014. And so I think there's a lot of work we can do on the ground to really bolster food security for students and families.
And now, you mentioned SNAP cuts. I mean, it's being projected that over 2 million people could lose their SNAP benefits over the next decade. What can you tell people about the work that's being done on the ground? Is there a way for families, for schools to sort of protect themselves from some of these consequences we're seeing on the federal level of spending cuts, of SNAP cuts?
It's a great question. I don't know that I have the answer to that, but I do think those solutions start locally in a lot of ways. And listening to parents, listening to community members, being responsive to their needs, and then working out solutions that meet the local population's needs is a really critical strategy to employ.
And I would love to jump in on the policy behind that, because when we think about the changes that they've made to the SNAP program last summer, there is a cascading impact that it would have on school meals, because if kids lose SNAP, which some of the decisions states might end up making because of the costs that are being shifted to states, if kids lose access to that, then they lose their direct connection to school meals, and that actually harms a lot of the work that we're doing around healthy school meals for all. So we really need to make sure that as states are implementing these new policies, that they're doing it in a way that they're putting the state funding in there to make sure that the SNAP program is able to continue to operate, that they do their best to mitigate the harm, and that they communicate clearly to families the changes that are making so that no one's surprised by it. So we actually have a lot of work to do over the next couple of years to make sure that we mitigate the harm from these SNAP cuts, and then also actually advocate to try and reverse them. SNAP is one of our strongest, it's our largest federal nutrition program. It combats hunger, it improves nutrition, and it lifts millions of people out of poverty, and we need to be strengthening and expanding that program, not contracting it.
And one more thought on this too, I think just thinking about all of this dependency in general and really strengthening our partnerships, really looking to the healthcare delivery and healthcare insurance side on these upstream impacts like food. And I know we'll have a later talk about food as medicine, but really trying to leverage and think about other partnerships is another area I think we all need to work on.
In California, what is being done, or what were you excited about seeing in school districts when it comes to trying to mitigate the impacts of these SNAP cuts?
I think we're still struggling with that, actually, to be really frank. And then the other really hard part is that it's not just the actual direct nutrition, but our nutrition education. So on the public health side, it basically 95% of our nutrition and physical activity branch was funded by SNAP Ed, and now that has been completely decimated. So again, really trying to work with other partners to figure out how to make up for these big gaps that we're now seeing.
Contextualizing that, I mean, have you seen that level of cuts, that level of changes to something like school nutrition education programs, prior to this administration?
I don't think I have. I think the level of cuts to many different programs has really been unprecedented.
Yeah, I mean, they cut SNAP by about 20%, which is completely unprecedented, and the requirement for states to cover some of the benefits is a huge shift and incredibly problematic too, because there is a significant variation among the states with the resources that they have to put into the SNAP program, and then also the political will that they have as well.
Is there anything that brings you, I guess, hope, conversations you're seeing with legislators, or ways that people are organizing on the ground, when you look at the after effects of these cuts?
I can take that one first. One of the schools I've been working with is expanding their backpack program in advance of these SNAP cuts, knowing that they're going to have a greater need for students to be able to take food home on the weekends. And so they got ahead of this. They're working with teachers to identify additional students, and really working with the food pantry to make sure that families are food secure.
That's great. At least that's a point of hope. That's exciting. It looks like we are out of time, but thank you so much. Thank you.
Please welcome Dr. Tara Maudry, Assistant Professor at University of Michigan, in conversation with Dr. Donald Warren, Co-Director of the Johns Hopkins Center for Indigenous Health.
Hello, and thank you to all my relatives here today. On behalf of the Center for Indigenous Health, we're just so pleased to be at the table and part of these important discussions. And we also appreciate the land acknowledgement to start this meeting. That was wonderful. I show this map to emphasize the fact that colonization has had a huge impact on Indigenous peoples worldwide. This is just looking at the lower 48 states. But keep in mind that with the loss of land and territory, it wasn't just sacred sites and locations, it was also food systems. So entire food systems were disrupted as a result of colonization. And when we think about the access to food since that time, we became dependent on federal government food programs, including programs that were rations for food and commodity food programs. So now a lot of people think of fry bread as traditional food. And fry bread is not a traditional indigenous food. It's people doing the best they can with their federal commodity foods. So we never fried dough. That is not a traditional indigenous food. But just very briefly, I'll show you a picture of some of the old commodity foods, things that I even grew up with. And I just call your attention to the picture on the right. That's a large container of corn syrup. I know it's in very fine print, but it says use in baby formula. So this was part of our history in terms of the food that we've had to endure. But we have good news as well. We have a lot of good programs. I'd love to hear from Dr. Maudry.
Yeah, thank you so much, Don. I want to ground this a little bit in some examples from my own community. So I come from a commercial fishing family, and I'm a descendant of boarding school survivors. And as a reminder, today is Orange Shirt Day, which is a day of remembrance for the many people that never came home from those boarding schools and the continued trauma that our communities continue to face. So to talk a little bit about my community, I mentioned I come from a commercial fishing family, and as we've seen over the last few years, we've had a lot of environmental injustices within our Great Lakes, and that has caused continuing decline to our whitefish populations. But the Sioux Tribe has done something really innovative, and they have the only inland walleye and whitefish ponds, and they're continuing to stock those waters with whitefish and walleye, really trying to give back more than we're taking with those fish. And that's a really beautiful example of how we're trying to preserve our sovereignty and our very ways of life in face of some of these environmental justices. And of course, the loss of knowledge from some of our boarding schools, that intergenerational knowledge that wasn't passed on. If you're interested in learning more, this documentary that the Sioux Tribe made is available on YouTube. So although Indigenous food systems are so incredibly diverse and there's so much beauty in that diversity, we do have some shared commonalities. And one of those is really that we think of nutrition in a very expansive way when we compared to how Western science sort of defines nutrition in very physical terms around sort of nutrients, servings, and calories. Our communities think about it more as physical, spiritual, emotional, and relational. And those components of our food system really cannot be separated from one another. And of course, that relates to how we think about addressing nutrition in our communities. This Indigenous nourishment model I've used to develop strengths-based Indigenous nutrition measures called the Indigenous Nourishment Scales, and I'm currently working with the Fond du Lac Band of Ojibwe to develop a nutrition curriculum based on addressing food trauma, really thinking through how do we address it through physical ways, spiritual, emotional, and relational. Speaking of which, it's been culturally adapted, this model, by people all over Indian country, and I'm truly honored by that. But speaking of cultural adaptation, I'd love to hear from Dr. Warren about how the culturally adapted Together Overcoming Diabetes intervention is going.
Yeah, we have a wonderful program called Together Overcoming Diabetes, and it does include, of course, nutrition and recommendations for traditional foods, but even in a much broader context. And it's a holistic curriculum that's intergenerational. So it's an adult with type 2 diabetes and a youth family member. So it's focused on diabetes management in the adult and prevention in the youth. And we just finished our phase 1 in South Dakota, and it was a shortened timeline with a relatively small number. There were just 40 dyads who participated, so half got the intervention, half did not. But we already saw statistically significant reductions in depression, anxiety, and blood pressure, and approaching significance for reductions in blood sugar. So we're waiting for phase 2. Of course, that's going to depend on whether or not the government is still open tomorrow. So happy New Fiscal Year's Eve, everybody. But we have a lot of examples in Indigenous populations that are very successful in terms of improving outcomes and utilizing traditional culture as part of the intervention. The challenge is, from a policy perspective, how do we scale that up? We need more resources and acknowledgement of these interventions as being valid and useful. And I would really think that from a policy perspective, that's where we need to see investment in traditional ways. I'll hand it back over to you.
Yeah, so thinking forward to really what's possible and moving beyond this food trauma, there's a lot of really exciting things going on in Indigenous communities, but also sort of an opportunity for everyone. I think Indigenous food system restoration work, there's sort of this misconception that it's just about Indigenous peoples or it's just for us. But we all live here together on Indigenous lands. And that's one of the biggest challenges is how do we live well here together? And how do we use these food systems together? And how do we learn from one another? And so as we think about Indigenous food systems, when we're restoring these relationships, it's not just about us. It's not just about our communities. It's about climate resilient ecosystems. It's about neighbors that are helping one another. And it's really about thinking about how can our foodways be rooted more in reciprocity and in responsibility to one another and the people and the lands around us. So as we think forward to the future, I really hope that we can continue to have some hope as we work together and remember that this work isn't just for us, it's for everyone, and we invite you to be part of that work with us.
Pilamaya, thank you all very much.
For over a decade, I worked in food service and farming, planting seeds, serving meals, and feeding people one plate at a time. But it wasn't until I joined Hunger Solutions New York that I truly experienced firsthand how access to nutrition can transform communities. Our statewide organization focuses on federal nutrition programs, including summer meals, ensuring that kids have access to adequate nutrition when school is out. This summer, I rode along with Saratoga Springs City School District's food truck, and I got to witness smiling kids run up, knowing that lunch was waiting. And at Pine Bush Central School District, I stood with the food service staff who were supplying over 900 meals weekly to families. And then in rural areas, I supported libraries as they stepped in to offer grab-and-go meals for families in their communities. These institutions and then the staff that supports them, they're lifelines. But today, we're facing real challenges. SNAP cuts could mean that families, fewer of them, they qualify for these food nutrition supports, and then also that fewer organizations are eligible to serve these meals. So these policies, they have real consequences, and we're seeing them play out. Yeah, I believe in the power of federal nutrition programs to support and bolster our communities by providing stability, dignity, and connection. And at Hunger Solutions New York, we're not just working to respond to hunger, we're really working to restore hope. And as so many in the food access and anti-hunger space have said before me, these programs are not a handout, they're a hand up. And it is now my pleasure to introduce 4 individuals who know about the power of food firsthand. Dr. Stephen Chin, Chief Medical Officer for Alameda County, Erica Hansen, Clinical Instructor at the Center for Health Law and Policy Innovation at Harvard Law School, Jordan Smith, my fellow Bloomberg Fellow from the Hawaii Good Food Alliance, and our moderator, Dr. Eli Moy, Bloomberg Assistant Professor of American Health.
Thank you. Good afternoon, everyone, and thanks for sticking around. I know folks are hungry, but I promise you you're in for a treat. I am so delighted to be sharing the stage with a fantastic panel here to talk about food is medicine. Before we dive in, though, just to do a quick grounding, in case folks are not familiar, I wanted to ask Erica if you could kick us off and just share how you define food as medicine.
Sure. So at its base, food is, or food as medicine, is the provision of healthy foods for the purpose of prevention, treatment, or management of chronic conditions with a nexus to the healthcare system. So this could be a prescription, a referral, or even payment by healthcare.
Great, thank you. That's really helpful context. And now, if you could help just bring this to life a little bit more, Stephen, if you could share what this work looks like on the ground in your community.
Sure. So I want to just share that we're one of the handful of programs in the nation that's asking the question, the three critical questions: where does food come from for these food as medicine programs? How is it grown, and who is it growing by? And we answered that question in the design of our program, and I'm going to break it down in terms of a few points, a few ingredients. Our program is called Recipe for Health, and we're in Alameda County. And the first ingredient is our safety net health centers. So we base this work in community health centers. And what's happening there in our county is 18 clinics, and clinicians across those clinics are prescribing food and health coaching to treat, prevent, and reverse chronic conditions, and to address food and nutrition insecurity. That gets us to the second ingredient, and that second ingredient, it's not just any kind of food, it's food that's grown locally, organically, regeneratively, and as many BIPOC farmers as possible. And we're putting that together into something called a food pharmacy, spelled F-A-R-M-A-C-Y, because we're connecting this food from 45 local farms growing for our clinics, and a food hub that's doing doorstep delivery. So our patients are getting discrete delivery of these food boxes to their homes or to their doorsteps weekly for the prescription. And then the third ingredient is we couple this with health coaching to create a behavioral pharmacy so that we're amplifying the effect of the food through movement, through social connection, through talking about the food that they just got in the weekly box. And those are our three pieces of the ingredients. The final one, the secret ingredient that puts it all together, is our administrative and training ingredient. And that's my team at the county. We're a small and mighty team, and we bring this ecosystem together. We train the clinicians on how to use food as medicine in a 15-minute visit. We train the medical assistants to screen for food insecurity. We make sure the farmers get paid. We make sure our health coaches get paid, and we bring it all together. By connecting the sourcing of the food to food as medicine, that's my call out, we create a health multiplier. And that health multiplier is not just human health, but we also get economic health and the ecological soil and climate health all at one time. So that's kind of how it is on the ground in one program.
Yeah.
Give you a taste.
Thank you, Stephen. I really appreciate how you're using food as medicine, not just to address food needs. On top of that, really using it as a leverage to spur broader food systems change. I'd like to next go over to you, Jordan, and invite you to share what food as medicine programming looks like for you and your community. If you could share a little bit more about that.
Definitely, thank you. I think building off of Erica's wonderful definition, I think food as medicine is also this alignment, right, this acknowledgement by the federal and state governments that what Indigenous folks and communities have known for a long time, that the connection between health, land, food, community is inextricable. And once one of those are unhealthy, it's all, right, they're all unhealthy. And so in Hawaii, that's really the foundation of everything that we do. Aina accountability. Aina means that which feeds. So we're accountable to people, we're accountable to land, we're accountable to the sky, right? And so we're really focused on prescribing Aina education, so bringing folks to the farm, to the garden, putting their hands in the dirt, seeing and feeling where that food is coming from. We're really focused on, as much as possible, 100% locally sourced, medically tailored meals, healthy meals, produce prescription boxes. We're supporting farmers, and we're also really focused on reintegrating and reconnecting folks to their cultural foods.
Yeah, again, just another great example of this holistic perspective and how to use food as medicine to support and really celebrate cultural foods and Indigenous food traditions. Thank you for sharing those examples. We all know these are incredibly uncertain times, and especially for sustaining and scaling programs like food as medicine. And I'm wondering if you could talk about some of the challenges and where you see opportunities perhaps to be innovative and creative when it comes to funding and supporting this kind of work. So maybe Stephen, I'll go back over to you.
Sure, funding is part of sustainability, and I shared with you 4 ingredients. Our 5th ingredient is just using braided funding, and we're funding this through Medicaid, but we know Medicaid is under attack. So we're using Medicaid dollars to pay for food, which is unheard of in terms of our history of healthcare. But we know that it can't just be Medicaid. So we at the county have invested county dollars into our Food as Medicine program. And we know there's a role for philanthropy. So we're encouraging philanthropy to support this. So it's really braided funding. One of my colleagues said, systems level change needs system level funding. And so we got to get beyond just the pilot grants. We need to get to system level funding. Medicaid is one lever. We also pull down USDA funding as well. But I think it's going to be a braided approach given the federal landscape.
Yeah. Jordan, anything to add to that?
Yeah, I would add Hawaii also has a Medicaid 1115 waiver, similar to California. Hawaii was the first state in the nation to put in their application for nutrition supports, food as medicine, that they would prioritize sourcing from local farmers, local community-based organizations, and local growers over importing food, which Hawaii imports more than 80% of its food supply. And so this has presented a miraculous policy opportunity, but also a significant policy challenge. As I mentioned, healthcare is just getting their head in the game. Indigenous folks have been here for a long time. And so how do we bridge these two communities, these two systems, healthcare and food, which both have their struggles, right? And both have never really connected formally in Hawaii. And so how do we do that while preserving the community aspect and not losing that each community is so different, and that's what really should be driving our solutions rather than the top-down policy.
Yeah. And I'd also invite you, Erica, from where you sit, thinking about healthcare financing and policy, what kind of challenges are you noticing, and where are there opportunities from your position?
Well, I would echo everything that my wonderful colleagues up here said. They are the implementers on the ground, and it's where the rubber really hits the road. From my perspective, where I work with a lot of states and on the federal level, I'll just say that the programs that they've implemented are both replicable and also really adaptable to kind of all of the states that you all are working in. I know a lot of you are implementers of these programs, and we've seen this across the country, really taking these programs that have been proven successful in North Carolina and Massachusetts, where we've seen these rigorous peer-reviewed evaluations showing statistically significant reductions in ER visits, hospitalizations, and huge actual savings for the Medicaid programs by really investing in addressing these root causes of chronic conditions. And we've seen replications of what Jordan said in their 1115 demonstration in legislation just passed in Oklahoma to fund these services in Medicaid with preferences for locally sourced food and community-based organizations for delivering the services. Legislation this year was just passed in Texas and Wisconsin, as well as legislation in Alaska last year. So we're really seeing that even in these challenging funding times, that there is a real momentum behind this idea of how can we transform our healthcare and our food systems to have a more holistic approach. And I think the funding question is real. There's other sources of funding, rural transformation funds. You have to really find who your champions are, as Dr. Chen said. But the momentum is there. Just listen to your communities. I think we've heard that time and time again today.
Yeah, and as we close, just wanted to open it up to the panel. If you could share a call to action or concrete ways that those of us here in the room can contribute and to really help moving this work forward.
I'll jump in and just say, for the healthcare folks in the audience and my healthcare colleagues, ask the question, where does the food come from? Who's growing it? How is it grown? Really get to know the food and ag system. And to the farmers, know that healthcare is a possibility to help sustain a new way of doing farming, of growing food for our health. And then really, at the end of this is the nexus of the land and the soil. And so with that is the call. Don't just be siloed in healthcare and just taking care of our patients, or even just public health without thinking of the food and ag system.
Yeah, thank you. Thank you so much for sharing your insights. This is incredibly valuable. Appreciate it.
Please welcome back Dr. Joshua M. Sharfstein and Michelle Spencer.
What a terrific morning. Would you agree? I was asked to sum it up, and I have like 20 different bullet points based on what everybody said, and Josh was like, you can't do any of that. And so I want to remind you all of what our dean said to us this morning in terms of the power we have in ourselves, the collective power we have when we come together, when we think about how we do this work in community, in academia, with faculty, with clinical individuals, with folks who are in government, that we do not do this work alone, that we stand on the shoulders of each other, and that we're here to support each other. And it's the power that we have within ourselves and within each other. And also I wanted to note the importance of advocacy. And certainly we can't do this work without individuals who are advocating for the work that we're doing and for healthier, brighter communities. And so with that, thank you all again for the work that you do and the power that you hold within yourselves.
Great. A few acknowledgements. I want to thank all of the faculty at the school who are participating, and the dean, Pollack Porter, who has been there the whole morning. All the people who put this event together, Kelly Henning and her team from Bloomberg Philanthropies, Evoke, Tate, our photographers, Larry and Howard. We definitely have to thank them so that they are willing to make a few little tweaks before the photos are finalized. And the initiative team at the Bloomberg American Health Initiative has an amazing team. And we want to especially thank the producer of this event, Shannon Jones.
So one of the things that you are aware of, please check your apps. There's lots of skill sessions this afternoon. There are field trips. And certainly there is a reception this evening at the Reginald F. Lewis Museum that's in a short walking distance, but there'll also be transportation available. Please check your apps.
Check your app for updates. Now, we have one more thing to do here, and I hope you indulge us. Occasionally, Michelle and I ask you all to help us express appreciation for someone. A couple years ago in Baltimore, we all rose up and gave a standing ovation to the Health Commissioner of Baltimore, who was here after having led the city through the pandemic. And we'd like tonight or today to do the same. This will be the last thing, so you can stand up, come on up, and then we'll be done for a special person. To both Michelle and I, Jessica Layton from the Bloomberg Philanthropies. Jessica, come on up. Jessica is one of the major reasons the Bloomberg American Health Initiative exists as it does. She is the head of environmental health in the New York City Health Department. She worked at the FDA. She helped design the Bloomberg American Health Initiative, and literally every part of this initiative bears her fingerprints. And we kind of give her little thanks every year, but this year we decided to do the big one. And I believe there is actually some sort of something to give you, Jessica. Somebody, here we go. Oh my God. It says, to Jessica Layton, PhD, MPH, thank you for your commitment and unwavering support of the Bloomberg American Health Initiative and for not sending back any of the more than 100 monthly reports we have sent you since this initiative started. Your support has allowed our innovative approaches to advance public health research, practice, and education. We are forever grateful to you. September 30th, 2025. Before you go, we want to do one selfie with you and the award. And everybody behind us. So if you wouldn't mind, people can come on up if you're interested in being in the selfie. Here we go. Jessica, we're going to look this way. Michelle.
You're in the middle, Jessica.
Come on up. Come on up.
This way, Jessica. This way.
Turn around, Jessica. Hold up your award. Hold it up higher. Okay, everyone's gonna say thank you, Jessica. 1, 2, 3.
Thank you, Jessica.
Okay, excellent. Thank you, Jessica.
Thank you.
Okay.
Thank you all for joining us. If you have signed up for a site visit, please proceed to the registration area for lunch. Again, if you have signed up for a site visit, please proceed to the registration area for